get the green light from Aurélie. So welcome to everybody here in this auditorium in Lausanne, in the nice canton of Vaud in Switzerland. We're very happy to see people back after 3 years of absence. We had a virtual meeting last year that was quite well attended, but this is the first physical meeting again after 3 years. Definitely everything has changed since 3 years. The world is no longer the same. I'm speaking like a politician, but I think you know what I mean. Still happy to see all of you here. We have 150 people that will physically attend this meeting, which I think is a great success. Some people are still traveling, coming in, and we may even have some concerns that tomorrow it will be a bit crowded, but we are happy that you are there, seeing people from Romania, from South Africa, from many peoples in Europe, and even our guest, Chee Yang, coming all the way from Singapore. Thank you for being there. I think I won't speak too much. Maybe tomorrow morning during the first session, I'll give some more highlights. No history. I think we just need to go straight on. The issue with this hybrid meetings is that we have to stick to time schedules because our friends in Singapore and Hong Kong are waiting to go ahead. I think one important thing concerning these ECC meetings is always interaction and interactivity. That means that there will be no students. The students that will walk around with the microphone this year will be Natalie, co-worker in the CAT lab, will be myself. I think it's good to walk around, or any of you. I have asked Alex to turn around the microphone. Alex is from Iași, nice town in Romania, so take care. The reason is because everything is online, streamed all the time, so that means that attendees are looking at us from around the world, and I think they need to see and hear us. If you speak you don't speak in the microphone, nobody understands what's going on. So it is important because also don't be scared. Everything you say will be registered forever. So without any further delay, I think we should move to Singapore and Hong Kong. The spot here you see is over there. The reason why I'm standing here is because the presenters this afternoon will be asked. You will be the first to stand here, and you can use the remote that is over here. It will be difficult to laser because that means you will have to turn around. I'm not sure if we need that. We hope not too much. So that's a few housekeeping rules. Otherwise, I think we should start. There may be some hiccups with virtual meetings. You may have connection problems, whatever, but we'll try to solve them over time. Two other issues. The Congress bags we are in Switzerland. They are blocked at the customs. Customs. That means we don't have them yet, but we hope to get them tomorrow, at least by the end of the meeting. Just join. And the other thing, the program, the printed program, is here in the hospital, but it's lost. So the package of all the printed programs is somewhere here in the hospital. We hope to find it. Okay, Chee Yang, you want to take over? You have the microphone.
Okay, welcome to the first session of the 2022 edition of the ECC meeting. And to kick off the session will be the joint session between the Hong Kong and Singapore teams, two very small but influential islands in Asia. And I'll hand over to our chairs for today. From Hong Kong, we have Drs. Chee Yang Chin and Michael Lee. And from Singapore, Drs. Paul Ong and Jack Tan. Please.
Hello, everybody in Switzerland. I am CK Chan from Hong Kong, also representing Hong Kong stand. We are very happy and honored to be able to join ECC this year. Can you hear me clearly? Okay, so I have the pleasure to start with the first case. So the first case presentation would be by Dr. Alan Chan from Hong Kong. Dr. Chan is a consultant cardiologist from the Queen Elizabeth Hospital. He has great interest in the treatment of CTO intervention as well as the management of CHIP cases. So he's going to share a very exciting case for us today. It's titled The Dark Side of CTO Intervention. So we love to see how dark it is. So Alan, can I please?
Yes, thank you, Dr. Chan. Can you all hear me clearly? Can you hear me?
We can hear you.
Yes, we can hear
All right,
you.
okay, just to make sure that everything is okay. So it's my great honor to meet and to able to facilitate the ECC again, date back a couple of years ago because of the travel limitations. So without the delay, so I would like to quickly start my case. So about really a dark side of recent CTO interventions. So my patient is a 68 years old gentleman, smokers, present to us with F4 anginas with a chronic angiogram by CTs in outside Tito shows two vessel disease. So we bring the patient to an angiogram, and in fact it shows a triple vessel disease with two CTO together with significant circumflex lesions. So you can see the LED as well as some of the outside CTO. So of course, because of the double CTO is always a good point to refer the patient to surgeons. The patient have actually normal renal function as well as normal LV ejection fractions. There's no evidence of pulmonary infarctions. But however, the patient declined CPG. So we bring back the patient for a stage PCI to one of the CTO first. So this is our target at first beginning. But a closer look of the angiogram of the left side shows that this LV is occluded, but also there's also occluded with from the atrial branch from circumflex. But where exactly is the LV stump? So LV I think is a little more challenging. For the outside, it's also challenging because it's a long CTOs, no interventional collaterals. Also very ambiguous cost. But for the LED, we can see some channels from the right from the conus branch, but where exactly is the LED stump? So at a routine self-shot with the bilateral injections, we are able to better understand the anatomies of the LED CTO. So as mentioned, the outside was occluded as not receptor collateral to distal LEDs, mainly some conus branch collateral epicardial one from the proximal LCA. Again, for multiple views together with the bilateral injection, it seems the LED join from the mid, but however, there's a very big branch somewhere here. Originally, we think it's the proximal LED together with diagonal, but when you see the bilateral injections, especially from the cranial view, it seems these two vessels separated quite apart. So probably it's not really the LED per se. And at the beginning, we suspected the LED was where the ostium is way high up, very close to the ostium. So as a routine for any CTO interventions, what is the strategy? So as by means of strategies, how do you proceed? So of course, it depends on what algorithm we are following. So we have a hybrid algorithm. We have also an APC algorithm. And recently, our colleagues from Hong Kong also published a so-called the global algorithm talking about how to intervene in CTO lesion. So of course, strategies would mainly include antegrade, retrograde, or how to resolve the proximal cap ambiguity. So as for these cases, this is what we kept the global algorithm. Whenever there's a proximal ambiguities, to see whether there's any side branch or interventional or feasible retrograde option. It's not really intervention, it's feasible retrograde options. So for this particular case, we have multiple side branch from some of the so-called diagonal or the Ramus branch from circumflex as well. And this is what we did at the beginning. We cut a wire in one branch and then take a close look from the angiogram. And this is what we get from the so-called diagonal or Ramus branch. This is where we pull back from the Ramus. So it's in fact this side branch is really big. It's almost up to 3-5 some point very disease long diffuse lesions. When you grade all the up here, I can't see any particular stump anywhere. And we join in here somewhere is coming, so we can see there's carina somewhere and a bifurcation, something like that, but it's not too sure again. We go further high up, these are even bigger branch. when we correlate with CNE, this is the proximal side branch, and this is the carina, so-called circumflex. I tried to dig in and out several times. In fact, this is what I guess at the beginning. There's some haziness or tissue plug there. Maybe this is some part of the proximal ostium of the LAD, but it's not pretty sure. So the IFS guided proximal cap and localization is not 100% sure. So how about retrograde? So feasible retrograde option is lots of different concepts for different interventionalists. For some interventionalists is interventional, but for others it's not. It really depends on the expertise and the experience and the comfort zone. For me, there's no retrograde channel, subtle channel. The only these kinds of epicardial complex channels, which I think is still feasible. So we take a sure free wire supported by a couple long microcapitals and take some try. And lucky enough, I don't know whether it's good or not, because the sure free wire can cross this epicardial channel all the way to the LAD, and this is where we get. So the retrograde MICAN was advanced all the way to the mid LAD, and we change back to a workhorse wire to take a feel of how hard is the of the lesion is. Again, I don't know whether it's good or not. The workhorse wire run through actually goes really high up somewhere here, and this is where we can quickly achieve this step around within less than, for example, 30 minutes. So everything seems in good progress. You see now my retrograde wire is close to somewhere here. Still, it's very off from the bilateral injection. Not too sure exactly the end sum is. So at that juncture, I take out the IPS again to check, because I came from the big ramus branch. So this is the carina again. You can see somewhere my wire is coming in. It's really odd at that juncture. I can't still really figure out where exactly is the location of the osteoarthritis. So again, here come with the key step. What will you do next? So we may have, you can briefly discuss. So whether you change the go, because my retrograde wire is very close to the left main. So option 1, stiff wire puncture. Option 2, change back to antegrade wire to perform reverse cut in the proximal LAD. Or third, try to use IFS to puncture the antegrade ostium again. So we may afford maybe any quick insight from the panel or chairman, or and other thoughts before I proceed.
Sure, maybe we can do a very short discussion. This is a rather challenging case. To take one step backward, I wonder if am I muted?
No, I can hear you clearly.
Okay. Whether a CT scan of the coronary angiogram would have some clues as to where exactly is the takeoff of the LAD, because even with the total occlusion, we might still have some clue as to where is the branching point of the LAD, whether this is a flush occlusion or actually first going into the LAD, you see that overlap with the diagonal. But of course, I
think this is a very
may not be available.
It's a very valid point. I think a CT angiogram is always is particularly for CT intervention. I think is always it's good, but in Hong Kong, you know, this is always a problem for us. It's hard for us to get a really a dedicated CT core angiogram before a CT intervention. But I totally agree with you. A CT angiogram will solve a lot of this problem.
For myself, I would at this point probably do some antegrade working, because that if I can get a wire into the proximal stump, although we are not quite exactly sure from the IFS, but at least if we can do the connection at the proximal LAD rather than at the level of the left main, that would make the procedure safer.
I agree with CK. If we go with the stiff guide wire from retrograde, you might end up in the subintimal plane, and then the ostium of the circumflex may be affected. So you are losing a lot of branches. So what I think we will do is try to go antegrade, but a better way, I think I will go with the IFS guide again, because since you have the IFS here, although you cannot locate the osteo-LAD very clearly with previous IFS, I think now we might actually try the IFS guide again, try to see if you can see that suspected LED again and try to wire from there. See if you can get the wire down.
This is a complication.
So yes,
if you agree, colleagues from maybe briefly, this is a complication session, so we have to anticipate that something will be going wrong.
Yes,
I'm just
looking at all.
looking at the audience and looking at time. Is there any burning point or question? This is a tricky case because, of course, we are not far away from the left main, and as you point out, Michael, this can be turned out into a nightmare quite soon. Is there something in the other? I see Nikolai, you're quite a TAVI expert. You can have the microphone. Just Alex, just one stair down. There, no, here. There's Nikolai. It's on. You can speak.
Okay. No, it's not. Okay. Thank you. Yeah, it's a quite complex case, and probably the next step is to engage the CTO body with anti-grade wire and to try to have some reverse card technique. Otherwise, you can be in trouble in the left main. That's
something you consider the safest option. Yeah.
Anti-grade.
Okay. I think we should, for reason of time, we need to go on, but maybe you can show us what you did.
Yes. In fact, as a CTO operator, you all know the retrograde nightmare. This is one of the potential nightmare for particularly retrograde wiring in the major sideline. So, but the problem of this case is you can see from angiogram. I think even though we have retrograde wire close to the stump, proximal stump, we still can't know exactly where it's take off. So, from the angiogram, I suspect it's a really acute angle right from the distal carotid ramus and then turn to the left and then up. So it's really odd angle. So even with the retrograde wire, and then I pull out the IFAS to do so-called real-time IFAS guide wire. And you can see my retrograde wire right here. This is my anti-grade guide wire. This is the real-time using the dual catheters with the same wire to so-called the slipstream techniques. You can see this is the anti-grade wire pointing towards the retrograde target. So even with this configuration, you can see because of the acute angle, this thing I use a very steep wire to make big angle, dual catheters. I have an extremely hard time to get close to the retrograde marker wire. So at some point, actually I can get in, but as you can see, what might ever happen. I hope my anti-grade wire puncture can be a little bit further down into the left main carotid instead of a little bit more proximal. You can see here rotational. You can see a little bit more proximal. So so this is the angel, and at that juncture, it's really hard. I think I struggled here for an hour with different wire, different angle, different techniques, different wire shaping, and then still can't really get a good, because you have a very big free space here, a very odd angle. So at that juncture, we presume we have a puncture in the proximal LED, and then hopefully a reverse card will be able to finish this case. But there's something get wrong because it is common section. It is angiogram. So I think you see the angiogram what hopefully is entering the vessel architecture to proximal, and is also confirmed by the anti-grade IFAS. You can see my wire actually joined in, but a little bit proximal to the left main bifurcations. There are lots of plug there. There's some hematoma. The hematoma actually getting jeopardized some of the flow to the ramus together with circumflex. So at that juncture, I need to quickly fix the sidebar first. This is what I get. Stand the circumflex as well as the ramus. So you can see some dissection over the left main. And this is after standing. So in fact, because of a lot of dissection plane, we already do some reverse card. Actually, the retrograde wire, this is still a very soppy, some kind of easily jump in back to the left main. But of course, checking from the IFAS, you can see the wire actually goes somewhere more proximal than the distal left main applications. So the option here is we're in a dilemma. We we did open some of the channel to the LAD, but it's not the best position. We already struggle around an hour that we have no chance to get more distally because of the acute, too acute angle of the osteo LAD. So the option will see whether we leave the LAD alone and then just treat the bifurcation of the left main, ramus, circumflex, and then probably bring back the patient to have a stage LAD CTO. Or we try another, we write anti-gradient, but this, I can tell you, is almost impossible at that stage. Retrograde, of course, I think with badly dissected left main bifurcation, I think is always almost impossible. So in fact, what we did is the first option. Another option is we try to use that Y, but we know that we were able to remain in a closure of the side branch. But we have the stand, we also the guide Y over the two side branch, so much so that actually we can able to establish it by means of some communication stealing techniques. I think once we open up the LED by ballooning, you can see why we come relatively far from the true Austin, because the retrograde Y actually goes right at the distal cap. So I can go back again. So this is the LED pullback IFIS. So this is the true movement, but when we go to the CTO bodies, the actually retrograde Y actually goes in the smooth plane because of the calcified lesions. So after stentings, this is what we get. We still get some flow to the side branch. Again, this is a lot of key discussions sometimes ago in our localities of how we treat this, how to treat these bifurcations. I mean, whether how to stent. We can still do some flow to the circumflex and ramus. So what I did is so-called the double fenestration of both side branch ostium. So again, this is not easy because we first of all have a stent in the left main bifurcation. We also have a lot of tissue in between the both ostium and the stent. So again, I need to use dual catheter, stiff guide wire, very angulated to puncture each of them. First of all, the circumflex and then the ramus. So in fact, it's almost take me 2 hours to open up this, to rewire these two important side branch. And you know, because I need to use a very stiff guide wires, including CP9. So it's very difficult to control the wire. It's lucky to go in a certain both of the side branch, certain segments. The wire actually go beneath the stand, it's go underneath the stand, but it still go in the true room somewhere back into this inside the stand. So both circumflex as well as ramus have the same problem. But anyway, I think that as far as my guide wires inside the true room in some of the stand, that this will be, I think it's still to be okay. So in order to make this procedure simple at that stage, already 6 hours since the start of the procedures, I decided to the traffication standing simples, of course, far from perfections. For the circumflex, this is a double tap. So I put in, this is the French guide, we can accommodate 2 stand and then 1 more balloon. So the circumflex stand, ramus stand was parked and then positioned as perfect as possible. And then this is a triple kissing and then final pop. And then this is the final angiographic result. So I may say the angiogram is okay, it's acceptable. The left main and the coronary is big. Of course, when you take a final pullback from the IVS after 7 hours work. So this is from the ramus pullback as well as circumflex pullback. Of course, you can always aim for even more perfect, better result. This probably the circumflex stand protrude a little bit out in the carina. So there's a so-called neural carina somewhere here. So, but the lumen is big. You might go back to rewire and do lots of kissing and then further crushing. Then I think it takes even more hours, probably additional 1 to 2 hours. I think everyone got fatigued. So I think comments are all welcome. Hopefully, in this case, I will share with you some of the tips and particular traps in tackling osteo CTO lesion whenever there's a major side branch. Of course, there's lots of methods to solve the proximal ambiguities. Of course, there is always in the classic landmark papers of the retrograde, the nightmare, avoid direct retrograde wiring to prevent major side branch compromise in any osteo CTO intervention with big major side branch, just like in this case. Always importance of using IFIS to solving different dilemmas. And complication during CTO interventions and some bail-off method for complex trafficking lesions. So thank you very much.
Okay, thank you, Alan. This is a very, very difficult case. You're very humble. I think the final result is very good. It's not just acceptable. You raised the question at the junction when the retrograde and the antegrade wire actually caused the section along the left limb. So I think that that was a very critical moment, because the circumflex and the big ramus branch is actually the single surviving artery supplying almost the whole myocardium. So I'm not sure what others think. So for me, maybe I at that juncture, I would just secure the cert and the ramus first, standing from the left main to the ramus, and secure the flow and see how it goes. But you're very brave. You go on and try to do to treat the LED CTO. Any other thoughts from others?
I think Alan is an amazing case, but this is also a course to learn about complications and also obviously to treat and avoid situation like this. So if for the fellows who doesn't obviously have the skill that you have to go and do a double fenestrations and triple stenting, if you were to teach again the juniors, reaching the same situation that you did, how would you have recommended others to do?
Yeah, I think this is a really important question. So I think just follow the CK's comment. I think he rightly pointed out that actually this particular case is challenging in terms of the anatomy. We have a double CTO, which from the left side is single surviving territory. So in fact, I don't disagree that the properly standing from the ramus together with circle. That's option one. Just lays out. Of course, we can always bring the patient back for an LED CTO intervention, sometimes take us. But it will be, I think, after standing to the main branch, it will be almost extremely hard again, because you have extra metal layers. So I think that it really depends. For a teaching of the fellow, probably safety is always come first. I totally agree, because in this particular case, in case the patient, the RCA is not a chronic total occlusion, probably the patient may have a little bit more high ischemic threshold, but I may say I'm fortunate enough for this particular case, the patient is doing okay. Of course, in other scenario, patient may be compensated or may have lots of ischemia, so much so that I may need to give up the procedure at certain turn point, or if there's no return, and I stand all the way from left main to everything. Luckily, I think the left main here, yeah.
If we follow CK's suggestion, you extend the osteo circumflex or ramus, and then we go with a very stiff guide via retrograde, so that you puncture and try to get into the stent. Is that an option? You think might be a safer option actually?
Maybe, yes. I don't disagree. But this I think this is form of some kinds of stand card, which is always, it's very difficult to get back. You always have problem. For example, retrograde wire can go again beneath the stand, and then
beneath the stand, yes, of course.
Yeah, this is the again another dark side of this retrograde CTO. This is the stand card, which is the reverse card. This is our favorites nowadays because of the issues. So I just want to bring out this case just to illustrate the potential complication of osteo CTO lesion. I think it's really the challenging point, and also express the decision making throughout the case, because I think at the end is a long case. Is really unpredictable at certain time points. This is also the beauty of very interesting point of doing a CTO intervention. You never know what's the next step.
We're always here in Lausanne. It's sitting inside and watching it. Although it's not always easy with the screen that is rather small, but it looks really quite impressive. And it's also clearly a statement to make that that we need CTO operators that definitely will not be potentially not TAVI operators, but more and more we see people subspecializing in thing. And for the sake of our patients, people like you need to do that. But maybe here in the room, maybe 5% of the people do that. You know, I think we have to be humble. Maybe I'm wrong, and don't take me, don't take it as an offense. Chee Yang, do you have any comment?
Amazing case. I'm still trying to figure out in my head what the left main looks like now, because you completely reconstructed it. But the final flow looked pretty good. I think I personally would have at many points throughout the case, if it was safe to do so, I probably would have stopped if it's safe for the patient, and then maybe recollect, gather myself again, have a look at the CT angio, because I think there was a CT angio done, which is why he was diagnosed in the first place, and then approach it again. But I think you showed why persevering sometimes is beneficial, and yeah, great, congrats on the good result.
So maybe in the interest of time, should we get a move on, or
Yep.
Eric, are you okay with?
Okay.
Yeah, we can move on.
Yeah, so maybe if this is okay, then maybe we can invite our next speaker, Dr. Yang Chin, who is from the National Heart Center. So it's a punchy titles, okay? Whoops, quite appropriate for this ECC meeting. So over to you, Yang Chin.
Thank you very much, Dr. Ong, for a very kind introduction. And I'm very grateful to ECC for inviting me to share some of my experience. This is a case that I did as a fellow, I think about 2 years ago, and I learned a lot. A 38-year-old gentleman who actually works with us came in. He's got a lot of strong risk factors, extremely heavy smoker, and he presented with recurrent chest pain for about 2 weeks, and our colleague ordered the early myocardial perfusion scan. Now, at rest, he was well, but when he got on the treadmill at stage 3 Bruce protocol, you can see very obvious sinister ECG changes. And to confound this, the pain actually occurred during exertion and had persistent chest pain despite stopping the treadmill. And hence, he was actually brought to the cath lab immediately for emergent angiogram. So I'll share with you the right coronary angiogram images first, and we see very large ataptic vessels with some non-culprit lesions in the PDA and PAV, and we then proceeded to check the left system. So this is a spin of the left system. I think I prefer doing a spin routinely as a fellow because it actually helps me appreciate the coronary anatomy. But slowing things down a little bit here, we can see that the circumflex is rather small. And at the ostium of the ramus, there's actually significant disease, followed by another lesion in the mid-shaft. Now, however, of course, we can see the culprit lesion is this very tight proximal LAD lesion. It results in TIMI1 flow, probably due to some thrombus. And at further down, you can actually see that the mid-LAD diagonal bifurcation is large, and there seems to be significant disease as well. So as the patient had recurrent chest pain, we proceeded to do ad hoc PCI and open up the proximal LAD. And this is the angiogram that we had. Now, this is where our dilemma started, because you can see that though the proximal LAD lesion is opened up well, you can see sort of a Medina 011 sort of bifurcation lesion that's rather complex, involving a very large diagonal here, as well as, of course, the LAD. Bifurcation angle doesn't seem to be too sharp, but there's a thrombus-laden lesion proximally. So we had a debate about whether to refer the patient for bypass, stent the patient, and what sort of stenting to use. Ultimately, we decided on a 2-stent strategy to tackle this lesion with a plan to do a QLOT, a DK QLOT, to try to reconstruct this bifurcation.
May I ask you just a short question? Because, of course, this is an emergency case in terms of antiplatelet drugs, because you take him straight from the treadmill to the cath lab. How do you manage?
Yeah, so we have carried ticagrelor in the lab. There's aspirin down in the MIBI lab. So the gentleman has received aspirin in the lab, in the MIBI lab, and also was loaded with ticagrelor prior to procedure. Now, we encountered, as always, the best laid plans always such, but we always encounter problems. So this is our first problem. When we started to instrument the diagonal branch, pre-dilate the side branch, we actually encountered a lot of slow flow. And at this point, the patient actually started to become unwell, chest pain, ECG changes, because we think that the proximal LED lesion is thrombus-laden and caused a lot of distal embolization. And this is where we took perhaps the first more controversial step. And we put in a true 5 sort of 33 millimeter stent all the way from the proximal LED into the side branch. And the idea was to kind of scaffold the proximal LED thrombus-laden lesion such that perhaps it will reduce the distal embolization. And after this step, we were actually quite happy because we saw that, there was less distal embolization, the stent looked okay, and we thought we could just complete the QLOT and get out of there. Now, the first step of DK QLOT is the first pot, followed by rewiring with another new guide wire. And you do the first kiss with, in this case, a 3.0 and a 2.5 non-compliant balloon. Now, my second mistake was the estimation of stent length. So for the proximal LED length, we were debating between an 18 or 22 millimeter stent. But when we took a longer stent, we realized that because there was some disease here, this stent we will end up landing in this sort of plaque-filled region. And hence we were faced with this dilemma whether we should just pull back the stent, push in the stent a bit more, cover a distal lesion, or we remove the stent altogether. And at this part, because that's after this is where the complication occurred, I would like to ask everyone's opinion what we have done in this case.
Okay, I must say, usually a situation like this, I'll just take it out and put the stent, which is the right length. But I'll be happy to hear what other people have to say. Michael, any comment from you?
For me, I think you are going to use another stent anyway. I might just push it down more distally, just stand the distal first, and then get a third stent, if you will, to do it more proximally, and then all the way back to do the DK QLOT.
You know what we do in Lausanne? If we choose a wrong stent, we say to the company that doesn't cross, and they give us a new one back. So it works.
That might work.
Yeah, maybe Nathalie, can you go up?
Does that too.
But it works.
Okay, yes. You want to carry on?
Cashback guarantee.
Yeah, that's something, Prof. Eric, that we're going to try the next time.
We have a comment from the audience. Yeah.
Just as well, thanks. It's a complex case, but did you consider imaging before you start stenting? Because I think it's quite a bit of dilemma there with calcified vessels. And the second question, was there a 2.5 millimeter stent in the proximal LED that you deployed and then redilated? I mean, 2.5 for a male patient, it might be a bit of tricky, a small stent. But anyway, I mean, was imaging considered at this stage before you start this complex procedure? Because I think it will give you lots of information on the stent length and when to land, which zone, and so on.
You're absolutely right. And routinely, we use imaging in our lab. This particular patient, there were two reasons why we didn't use imaging. And one of them, perhaps to share, is because patient had some financial difficulties. And hence, we actually tried to minimize the cost. As you see later, imaging is very helpful. And we ultimately ended up using imaging to help us solve this dilemma. And the second question, to answer the second question, I apologize, I missed some steps. The 2.5 NCs, the 2.5 stent here was actually post-dilated to a 3.0 here. So it's 3.0 in a sense in the proximal LED.
So one last question before you go on, Christian?
Yeah.
The lesion is very long, so you have the stent in place. So I think it's the best idea for me. It's to put the stent distally, and after that to finish with the culotte stent of the LED and diagonal with another stent, because the stent is open, the stent is in the coronary. So it's I think it's better to put the stent a little bit long distally to cover all the distal plaques of the LED.
Yeah, and in retrospect, perhaps that should have been what we did. I'll share with you what we did or didn't do. And also the other consideration we had is that this was rather young male, so if we tried to extend the stent too long, it may lose the option of bypass or limit the option of bypass in future. But then what we did was actually we tried to pull back the stent, but the position wasn't very ideal. We will end up scaffolding a lot of the proximal LAD. And as Dr. Eric mentioned, we actually thought about we actually wanted to take out the stent and put it in the ramus in future. So for the rest, at the end of the procedure. But what happened was when we pulled back on this stent, pulled too hard, there was resistance at the proximal LAD. And basically what we did was actually dislodge the stent. And what you can see on the cine here, you have a dislodged stent. And the 22 millimeter stent has been actually dislodged within the 33 millimeter stent, perhaps because, as our colleague mentioned just now, this area could be a bit underexpanded. The stent struts could have caught on to the 33 millimeter stent struts. And when we were pulling out the system, we actually dislodged the entire stent. At this point in time, I was a bit flustered and I wasn't too sure what to do. This is also an area that I thought would really benefit from everyone's thoughts, how to approach this problem of a dislodged stent where the guide wire are no longer in situ.
So the floor is open for discussion. Nathalie, can you just over there, Michael? We have some comments from Lausanne. Maybe if you agree, just to say where you're coming from, because also nice from the people to know.
Okay, can you hear me?
Yes, perfect. Yeah.
Okay, I will rewire the LAD with another wire, and I will crush this stent at the wall of the vessel, and I will try to restore the flow as soon as possible. Then I will transfer the patient to have a bypass operation.
That's a clear point of view. Any other opinions? Paul, Michael, what are your thoughts?
Are we getting flow at the moment, Yann?
Yeah, so fortunately, at this point in time, the patient was stable. I don't have the angio for this, but we actually took a shot after this. We engaged the guide. Fortunately, the flow wasn't affected. The patient was very stable. So in a sense, it gave us a bit of leeway.
So I will try and retrieve the stents, and once the stent is retrieved, if you are successful, then we just finish the case in whatever manner you want to do. And the way to get this stent out, I think there are multiple techniques you can try. You can try and snare it. You can try and double wire it and try and loop it out. And if all else fail, you probably just push the stent to the side with a bigger balloon and just stand it to the side.
Is there any way that you can wire through the lumen of the stent?
That's right, Mr.
Might take some time.
Yeah, you're right. Those are very valid points, and I'll share what, if you're right, I'll share what we did.
There's another point maybe at this stage, because you have a guy who is almost naive in antiplatelets. So I think we have a lot of metal there. Did you have any other consideration of adding, the old-fashioned anti-2B3A, or even giving IV other drugs to secure at least the issue of thrombosis?
That's very, very, Prof. Eric. We didn't think about that, and I think if I encounter this problem in future, perhaps 2B3A inhibitor would be very, very helpful to reduce the risk of stent thrombosis.
One more last comment from Alex from Yashi.
Hello, I am Alex from Yash. I would have tried to retrieve the stent using a guide extension and a snare through the guide extension to protect the left main from dissection. Because the stent is trapped in the stent, I can pass the guide extension like right next to the stent, and I'll try to retrieve it through the guide extension to protect it. But gently.
That's clear.
So our options were, as everyone has already rightfully mentioned, either try to retrieve the stent, rewire, or at worst case, crush the stent. So this was actually understanding the anatomy and the problem. I think we had this figure in mind that we were going to try to rewire, to secure access. And we gave ourselves a period of time, perhaps about 20 minutes. If we could rewire through the stent, then we will have a lot more options. But if not, if we could wire only outside the stent, then we will just have to crush it and complete the QLOT as planned. So this was our first attempt at wiring. And by feel, you can feel that this is probably outside of the dislodged stent. The wire, I think this is a run-through guide wire, and felt very, very gritty and didn't move very smoothly. So after about 20 minutes, then we found that the guide wire went very smooth at this point. The wire actually passed from here and could go very smoothly into the diagonal branch, which was stented. So at this point, we felt that it's possible that we actually crossed through the dislodged stent. And with a bit of manipulating, this was all with the help of a senior operator, done by a senior operator who bailed me out. He managed to redirect the wire through this side branch stent and into the LED. And at this point, we felt quite confident that most likely we had actually managed to wire through the dislodged stent and secure the LED access. So given the patient was quite stable, we continued to dilate this dislodged stent with a 1.5 and a 2.0 balloon. And as mentioned, imaging was very important. So despite the cost, we actually took out the IVUS. And we proved that at this point, you can see a dislodged stent here, small dislodged stent. And the dislodged stent occurs very close to the previously deployed 2.5-33 side branch stent. So we did further post-dilatation. And this is the angiogram. You can see the flow is good. The other wire was in the LED as well. And we did another IVUS run. This is the plaque-free or relatively disease-free area that we were aiming for initially, followed by a tight lesion due to probably plaque shift at the mid-LED. And shortly after that, you'll see that the mid-LED stent will come up. And essentially what we've ended up doing is scaffold the proximal LED with 2 layers of stent. And because the IVUS run is rather long, I will fast forward a little bit to the proximal segment. And you can see 2 layers of stent overlying. Fortunately, there's not much damage to the rest of the vessel. So we managed to decide to use a shorter stent here, I think a 30mm 2.5 stent, do the final kiss, followed by the final pot. And this is the final result. The final IVUS showed no stent edge complications. The stents were well expanded and angiographically acceptable results. We decided to leave the ramus alone as it was already a 3-hour procedure and the patient was finally stable after a while. And we planned for stage procedure. And he's actually been followed up after a year and he's actually had no recurrent stent events in the LAD. So my take-home points for this as a junior fellow was at that point in time, I learned that anytime you encounter resistance, you should never push or pull too hard. And it's someone wise actually suggested that, instead of pushing or pulling in the same direction, you should actually stop and reverse the motion. In this case, perhaps by reversing motion, we will actually be able to dislodge the entrapped stent struts and be able to pull it out at a different angle. And another bit of advice that I've gotten over the years is that if you feel that a stent is about to dislodge, before you dislodge it, perhaps deploying it in a safe place is a lot better than having to deal with a dislodged stent. With that, I thank you very much for your attention, and I'm very happy to take any comments.
Thank you very much, Shan. Maybe I will, congratulate you for managing to, salvage this case. But I'm curious, you were able to wire through the stent. Why not make an effort to retrieve the stent, but instead of deploying it?
Thanks, one of the thoughts we had was that likely the proximal bit of the stent was already enmeshed or entrapped within the previously deployed sort of 2.5-33 stent. So we felt that it was quite unlikely that we will be able to pull the stent out, and by pulling out the stent, we may actually end up dissecting the left main and injuring the rest of the vessel, and that's why we were rather hesitant about doing so, but that's a very valid point. Perhaps we should have tried a small balloon to inflate it and trawl it out, try to trawl the stent out?
I agree with Paul. Probably I would, as you said, use a smaller balloon going to the distal end of the stent and try to see how hard I can pull back the stent. If it is very easy, then by all means you can take it out. If you encounter a lot of resistance, you can always leave it there and then do the dilatation and then deploy the stent there. And probably I will use a longer stent for the third one for the third stent, so that cover the distal sort of moderate disease as well. But I know it might be more difficult to pass through double layer of stents with a longer stent. But probably I would use a longer stent to cover the distal part as well. But it's very well done and good illustration of how you handle such complications. Congratulations.
Yeah, good job, Yann Shan. I think you proved that wiring through a dislodged stent is possible, although it's difficult. Yeah. I just have one comment. I think I don't know if this really was your sequence or not, but when you took out the IVUS, maybe did you do it before you inflated the stent? After you rewired the stent, did you inflated it with a 1.5 balloon? You said, right? Yeah. Did you do IVUS before doing that, or were you so confident that you just inflated it with the 1.5 balloon?
Well, we thought that it was very unlikely the IVUS would pass through if we hadn't dilated. So we actually dilated first, then passed the IVUS down.
I guess the other way you could have done it was to put a parallel wire, yeah, and then IVUS from the outside, just to be sure that you're in. But yeah, otherwise, good save, yeah.
I have a question for the audience. Who in the room never lost a stent? Okay, you're all experienced interventional cardiologists. Congratulations. No, you agree, huh? If you never lost a stent, you're not done enough cases, yeah.
Eric, you should ask, how many stents have you dislodged?
Oh, you're asking me?
In your lifetime.
I'll tell you privately. No, I don't know. Quite a lot.
How many stents? Yeah, that's right.
I
think all of us encounter such complications.
Yeah. There's a question there, yeah. Okay.
Hi, my name is Matthew. I'm from India. The first thing what I want to know, why you wanted to make this procedure so complicated? The thing is that as per your angiogram, the lesion was proximal to the diagonal branch. You could have put a small stent and come out rather than making this diagonal stenting everything. The distal vessel was occluded, but subsequently, once you have wired it, the distal vessel has opened. So why didn't you think of just doing a proximal stenting, and just for the acute situation, you could have just done a proximal stenting and come out? The second thing what I wanted is, why do you want to try a KEYNOTE when you could have tried a crush, DK crush or mini crush, and later you could have done a proximal an LAD stenting, and that would have made the procedure very simple. The other possibility what I thought is, you can do a proximal stenting if you would have gone with a single stent strategy, and if you could thought that the diagonal is still pinching, at least you could have done a drug-eluting balloon and come out. That could have also made the procedure simple. I don't know. You can.
Maybe Yann Shan.
That's a lot of questions.
Single stent strategy.
I'll try to answer those questions. But those are very valid points, and I think those all cross our mind. I think in the first place, in this rather young gentleman, after we re-established flow and the flow was good, we tried to achieve as complete revascularization as possible. The diagonal branch was very large. There was very significant disease as the ostium. 90% large vessel, more than 2.5, thrombus latent burden, so lesion. So all these fulfill the criteria, definition criteria for sort of complex bifurcation stenting. And yes, you're right. So in a setting where I didn't have senior backup, we probably would have just treated a proximal lesion, maybe even, and come back. I was fortunate to have a very senior operator by my side, so we decided to at least complete the LAD treatment. And in this case, the patient also had financial difficulty. So bringing him for another procedure will also have rendered more financial burden on the patient as well. The bifurcation angle was rather shallow. So you're right, DK crush has a lot of benefits. So in our lab, we've started using the DK Q-lot as a surrogate for those patients whose anatomy favors Q-lot. And perhaps, some bench testing shows that, there's some benefit to that. I hope I've managed to address some of these questions.
Yeah, that's good, Yann. We have one more comment from the floor. Yeah, I think it's not on yet, the mic.
Hello? Okay. Tito, Kabir from London. I was just wondering what antiplatelet regimen you consider for this patient and the duration of dual antiplatelet therapy, considering the length of stent and procedure.
So at one point, we actually did consider giving extended depth for this gentleman. On IVUS, generally the stents were very well opposed ultimately. So we actually kept him on just dual antiplatelet therapy, aspirin, ticagrelor for 1 year. And I've had the benefit of actually checking up, and the patient hasn't had any events. In fact, I think this is about 18 months from the procedure. He's already off his ticagrelor and on aspirin alone. And fingers crossed, I think he's been quite well.
Okay, I think thank you very much, Shan. I mean, it's a brilliant case, and thank you for sharing. You know, really learn quite a bit about, you know, when stent get distortion, what are the things to look out for and what are the bailout strategies. And thank you for also going through your thoughts on whether you decide, how you decide to choose single stent or choose a two-stent strategy here. But I think, you know, we have a quite an important lecture coming up. So maybe I'll pass it back to you, Eric, so that you can introduce our next speaker.
Thank you very much, Paul. It's indeed a pleasure, and I'm really happy, Chee Yang, that you decided to come over all the way, and I congratulate you to take the right spot over there. So I asked you this task, maybe a little bit not that easy, to talk about how we as cardiologists, but not only cardiologists, physicians, I would say, live in this strange period, post-pandemic period, and how we meet up again or how we don't meet up, and how these kind of virtual or hybrid meetings go along. So thank you very much.
Thanks, Eric. Let me just start by saying what a great pleasure it is to be standing in front of a room of physical people after 2.5 years of speaking to my computer screen. So it's a great pleasure to be here. Thanks for the invitation to speak. My name is Chee Yang. I'm from Singapore. I'm a consultant cardiologist, obviously. When I'm not in a cath lab, my interests are in medical education. I have a master's degree in clinical education. I'm a director of the cardiology training program in the hospital I work with. And I also have several teaching positions in some of the local medical schools. So the title of my talk is You're on Mute. You're on Mute being a phrase that we've become so comfortable with over the last 2 years, when perhaps before that we hardly ever used it or heard it. In fact, that was the quote of the year in 2020, according to some sources. Yeah, and apparently we used this term 4 times more frequently in 2020 than we did before the pandemic. So the pandemic really has changed, many things. Obviously, it's changed our vocabulary. Just out of interest, last year's Oxford word of the year was vax, in the sense of vaccination and vaccines, because obviously it was the hot topic, so it's quite appropriate. And here are some of some common phrases which we are now so used to, which 2 years ago we would hardly ever use these. You're on mute. Can you see my slides? Your video is off. Perhaps more worryingly, your video is on. Stay safe, everyone. Almost every meeting ends with that. Yeah. So yeah, I mean, and of course, learning and the way we communicate with each other has had to change as well, with movement and group size restrictions. The classic, classroom or boardroom style meetings no longer worked, obviously, right? So many things had to change. This is just a very simple paper that a few colleagues and I published right at the start in a medical education journal, really just to describe our own local experience of how we adapted to COVID-19. And I think, what we found was that most people were very accommodating. I think both learners, teachers, they were very accommodating to the changes that had to be implemented, because everyone knew that we were kind of in the same boat. It's not by choice that we had to do this. So, people were okay to make changes. Education had to carry on. Yeah, we moved things online, obviously, because that only made sense. So that obviously gave a classroom, and scenes like this became very commonplace, right? You take one glance at this and you know which era we're from. And obviously, online worked. Online made sense at the time. It was low cost, wide reach, and accessibility. You could log in from any corner of the world to listen to a webinar as long as you had the link. And obviously, the facility of being recorded allowed people to continue to access the content on demand offline. So lots of webinars, lots of conferences moved online. So it was fun in the beginning, I think. It was a novel kind of situation. It was interesting to meet your old friends in a different kind of setting. You could see their clinics, you could see their office, you could see their homes sometimes, right? And it was fun to share stories about how you were coping, how they were coping, etc., etc. But has interest in the online format started to wane, or is it getting stronger? So do we take webinars and online meetings as seriously as physical meetings? I'll be the first to put up my hand and say this is not far from my standard attire when I attend an online meeting. Top half is very professional, bottom half is comfortable. And obviously this doesn't mean we don't take meetings seriously, but I think my point is that we take certain liberties with online meetings that we maybe don't take with physical meetings. And this is just an example of a classroom tutorial that I did with some medical students. Supposed to be a face-to-face, obviously, but went online and he fell asleep. This probably wouldn't. People fall asleep in lecture theaters all the time, but this was supposed to be a face-to-face kind of meeting, and I don't think he would have fallen asleep if it was a real face-to-face meeting. So maybe do we give the appropriate respect to online meetings as we would to a physical meeting? So how much do we value webinars or online sessions? How much do we learn? Obviously, it's very difficult to measure all this kind of thing objectively. And maybe the best or the closest we can get to it is through surveys or questionnaires. So there are a few of these published out there. This was from, again, a medical education journal. This was a survey of urologists. And you can see that it's right at the beginning of the pandemic that they did the survey, June, July 2020. So it's probably only about 4 to 5 months into the pandemic for certain people. And the survey or the questionnaire really was trying to assess people's perception of physical meetings versus online meetings versus hybrid meetings. This was their summary slide. It's very busy, so allow me to summarize it for you. In terms of the overall experience, most people felt that a physical meeting still gave a slightly better overall experience. In terms of things like opportunities for social networking, for research collaboration, physical seemed to score better. People felt physical meetings gave them a better opportunity to do these things. Where online did better was obviously cost effectiveness, but perhaps importantly, for scientific value and for the availability of up-to-date information, people valued both physical and online kind of similarly. All right, so there is benefit or there is value in having meetings online. This is another paper. This was not from urologists, this is from more a diverse range of physicians. Again, it was an online questionnaire. Just show you a couple of their questions, which I thought was most interesting. Question is, have you felt overwhelmed with the number and frequency of webinars and online meetings during the pandemic? And more than 70% of people said they agreed or strongly agreed with this sentiment. And I think most of you probably will agree as well that there's just so many webinars out there these days. Every other day you get some email blast out, So it's kind of overwhelming these days. But when asked, do you agree that webinars and online meetings can replace in-person meetings after the pandemic? Again, more than 70% people said they agreed or strongly agreed. So again, people saw the value in having online meetings. People still think that it would be useful. But perhaps what we want is quality, right, over quantity. So that was in 2020. I forgot to mention that paper was, that survey was done in November 2020, so a bit later on in the pandemic, but still within the first year. So that was in 2020, what about now? So I did my own little survey. This was at the end of a webinar, a regional one, so mostly Asian Pacific attendees, about 2 months ago. So main aim I was trying to get at was to assess people's interest in online webinars now compared to 2 years ago. Are people still interested? And again, it was a very simple Likert scale kind of questionnaire. Out of the 386 people who attended the webinar, only about a third responded. Yeah, so there's definitely going to be responder bias, and it's not the most diverse kind of population to start with anyway. But nonetheless, I asked the question, of all the webinars that you have been invited to between 2020 to 2022, what percentage did you actually attend? So I asked people to score whether they attended less than 25% of what was available to them, 25 to 50%, 50 to 75% if they attended more than 75% of all the webinars that were available to them. So you can see people responded that in 2020, quite a large number of people, the gray and the yellow box indicate the people who attended more than 50% of webinars. So in the beginning, everyone was very hyped up about all this, and a lot of people attended, more than half of the meetings that were available to them. 2021, that proportion kind of reduced, and in 2022, that proportion reduced even further. So of course, this could be a function of the fact that there's just so many webinars out there that we can't be attending everyone, or people are just starting to get a bit tired and a bit fatigued by the webinar format. The top 3 text reasons for decreased interest in online webinars over the last 2 years: too many webinars available, content is repetitive, every big company has a webinar on left main bifurcation. And I think what's important also is the difficulty asking questions. Difficult if you're an online audience or someone logging in to ask your question, and sometimes even if you type it in, it may not get addressed. Yeah, so it's difficult to get your question answered if you were an online attendee. The top 3 text reasons for continued interest in online webinars: the ability to hear different expert opinions. I think that's quite important. Sometimes we get true experts logging in from different parts of the world, sharing their insights, so that's sometimes not available in a physical conference. Usually it's free of charge or very cheap. And convenience, as we mentioned earlier, and offline availability. I added in reduced carbon footprint. It was only mentioned once or twice, but I think this may be an important issue, perhaps, for the younger people in future. Now, a bit controversial, but what do our industry partners think? So I send them a survey as well. So I gave my local industry representatives, so I aim for people in managerial positions or higher, yeah? So hopefully so that they have a better idea of the company's sentiment, etc. So I sent them out a questionnaire just a few weeks ago, one per company, anonymized, yeah? And asked them a few questions about how they felt about things moving forward. So I asked them, comparing online versus physical events for physicians, which does your company think is more effective for product education and marketing? But more than half still thought physical was more effective. Yeah, about a quarter thought online was more effective. I asked them how they saw the future format of educational conferences. Vast majority thought it would be predominantly hybrid, such as the one we have today. But 20% thought we would revert to predominantly physical only. And compared to pre-pandemic times, how prepared is your company to support local physical conferences if we were to have them? More than half said they would be, still quite keen to support our local physical conferences in terms of sponsorship, etc. 20% said that they would be less keen now. I guess they've seen the ability to save some cost, perhaps. And in a similar vein, how compared to pre-pandemic times, how prepared is the company to support physicians to overseas educational events? And again, about half are still quite keen. 30% say they would be less keen. So is hybrid the best of both, or is it the worst of both? I think we have to see whose point of view we're looking at. I think for attendees, even though it's a hybrid conference, if you're an attendee, you're only attending one version of it, right? Those people logging in right now, they're logging in, they're getting the benefits of the online version, but they're not getting the benefits of being in the physical audience. So for the attendee, they can never get the benefits of both. Yeah. For the course organizers, the major bonus, I think, is the ability to have people logging in, faculty logging in who are not able to come physically. They log in, give their opinions, such as what we had just now. Yeah, so that would be a major bonus. But is it sustainable? I think it's a lot, or maybe Eric can explain later. It's a bit more effort, I think, to have to focus not only on the physical part, but also on the online part. It's obviously going to be a bit more cost, more manpower. Some people to sort out the physical part, some people to sort out the IT part. It's more troubleshooting on the day, and I think I don't know if most people would agree, but there's no format that is ideal for both elements. So if you've got a format that's great for online, it may not be great for physical, and vice versa. So it's very hard to have a meeting that is perfect for both. So something's got to give, right? So if you want a perfect one for the physical guys, then online may have to, cut back a little bit. Yeah. So in summary, ladies and gentlemen, I think you would agree that educational meetings are just not going to be the same post-pandemic. There is a very high interest now, right, for an online component, and I think this, we've seen what online can give us, and this is going to continue. I think there still is a strong demand for a physical experience, and that's why everyone is here today. Hybrid seems to be the model, I think, for the next couple of years at least. But I think, the increased cost and effort may well force some of the smaller meetings in future to, just pivot towards one way, see how the sentiment or how people gravitate over the next couple of years, and then eventually just settle on one format. Thank you very much.
Thank you so much, Chee Yang. This was really what we wanted to hear. And I think it's an eye-opener, and it's really, you just basically told us what we all think about this. I think maybe our chairs in Hong Kong and Singapore can comment on what we just heard from Chee Yang. Who wants to start? Michael, you're having Hong Kong stand in September. So for those of you who have never attended, you will not be able to attend because it will be a virtual meeting, rather virtual with a little bit of hybrid in Hong Kong in September.
Yes, we are going to do it in a hybrid manner as your meeting in Luzon, ECC. But congratulations, Chee Yang. It's actually, as Eric said, eye-opening lecture for all of us. I think that's the reason why you go all the way to Luzon to attend this meeting. We are all a bit fed up with all the web meetings, so we really want some physical meetings. But as you know, some places like Hong Kong, like China, we still have restrictions to travel. So no matter how much we wanted to go, we still are not allowed to leave our country to attend meetings because we have to come back to do quarantine for 1 to 2 weeks. 3 weeks for Chinese physicians. So that impose a lot of barriers to us. But I agree with you that probably hybrid meeting would be the way to go for the next 1 to 2 years. And then we will all more prefer physical meetings after all these webinars, what we call tired of all the webinars.
Definitely, certainly also, Michael, we had the pandemic that seems to be moving a little bit in Europe again. But then after the pandemic, we had another issue. We will not express the word. We already know what I'm talking about. But this on top was just the drop too much that had it, not going to happen. So Paul in Singapore, what is your vision? Have any comments?
I think, again, congratulations, Yann, for that really lovely lecture. I learned not to agree to giving lectures in ECC that easily because Eric always gives those really difficult titles for us to talk. But anyway, just a bit of thoughts. I went to Munich a couple of weeks ago for a very short course. 2 nights on the plane, 1 night in the Congress, and then come back. That kind of crazy thing that I used to do a lot. But I hadn't done it for such a long time. I remember when I was packing, my son asked me, "Dad, are you still up to it? This is pretty tough." And I kind of think, yeah, when I get back and say, yes, it is getting harder and harder, especially long-haul flights to go on a very short course. So wouldn't it have been nice if I, with hindsight, just did it online instead? The other thing that I thought, all of us now feeling very acutely is the cost of traveling is really, really very different from what it was. Air tickets are almost like 50% or 100% more expensive than what it used to be. And I'm not sure whether this will get better and once the economy get back to sort of more even keel. But at the moment, I can just imagine moving forward to get industry to sponsor you to go to meetings. It may not be as easy as you used to be. So that's obviously also a consideration. And equally, to get industry to sponsor conferences and all that, One of the big budget, of course, is getting the overseas attendants and faculties to come in. I think that cost part will also be quite a significant burden. But yes, it is nice to be face to face. I haven't seen, Michael and Eric for more than 2 years, 2.5 years, and I would love to catch up. And I think part of the on-site meeting is not so much just the educational content. Of course, it is important, but the ability to see friends, to network again, to discuss how things are going, that part I really, really missed. And I echo what Michael said. In fact, I would love to be able to go to Hong Kong stand to meet up with you guys in September too.
That's great. I take the opportunity to thank all of you. You are about 150 people who came here. I don't know how you managed it. We have people from India, from South Africa, from the US. We have Chee Yang. So really, thank you for being there. It is really difficult times. I also agree on the issue of sponsorship. I think that meetings like this one will be difficult to sustain. I think the big meetings, although they suffer also, they suffer, but they survive because they have other issues and other solutions. So I think we are in a new area and we have to live with it. There's not a lot we can do, just hope for the better. I think we need to go on, no?
Okay, shall we move on to the last two cases? So the next case is going to be presented by Dr. Ivan Tsang. Ivan is currently the Associate Consultant at Princess Margaret Hospital in Hong Kong. And his case title is Usual Complication with Unusual Treatment. Ivan, please go ahead.
Okay, thank you, Dr. Lee, for your introduction. So can you all hear me well?
We can hear you well.
Okay, thank you. So hi, good morning, good afternoon, and good evening to everyone. I'm Dr. Ivan Tsang from Hong Kong. It's my pleasure to share my case on the unusual management of a common complication of PCI. Okay. So calcification is a hallmark of atherosclerosis, which is progressive and correlates with the overall plaque burden. The presence of calcium is multifocal, but usually appear earliest in the coronary arteries. Coronary calcification can exist in different forms, ranging from cellular calcium inclusions visible only by microscopy, to calcified nodules associated directly with coronary thrombosis, and to dense shelves of calcium hardening chronic fibrocalcific plaque. Calcification remains a major challenge to PCI in terms of passage of equipment like wires, balloons, and stents, which result in higher risk of suboptimal stent deployment, angiographic complications, and adverse clinical outcomes. The presence of heavy calcification often coexists with other morphologic complexities such as plaque at the ostium, or bifurcation, tortuosity, diffuse disease, and also CTO. So let's jump to my case, who was a 64-year-old gentleman, a chronic smoker who had history of diabetes, hypertension, and hyperlipidemia. He presented to the emergency department with sudden onset of shortness of breath and chest pain. His blood pressure on admission was quite high, and the triglyceride showed cardiomegaly and pulmonary congestion. The ECG showed mild ST depression over the lateral leads and also T-wave inversion over the inferior leads. The Eeckhout was done on admission, revealed the ejection fraction was around 40% without any significant valvular dysfunction and also low pericardial effusion. The serum troponin I was mildly elevated to over 9,000. So he was put on BiPAP and the usual medications for myocardial infarction and heart failure, including antiplatelets, heparin, statin, beta blocker, and angiotensin antagonist. And after initial stabilization, he was sent to the cath lab for urgent coronary angiogram. So the left coronary artery was heavily calcified, especially the LAD, and there was a tight lesion at the mid-LAD. The circumference was relatively small in size, and one of its branches supplied the collateral to the RCA. The RCA was not only heavily calcified, but also very tortuous. There were filling defects over the mid and the distal RCA, which could either be thrombus or calcified nodules. So the plan was to perform PCI to both LAD and RCA. And I would like to stage the procedure and to tackle the RCA first as it was protected by the retrograde blood flow from the left side. So a 7-French MVC guiding catheter was inserted transradially, and the workhorse guide wire was able to wire into the PL branch, but the delivery of the balloon was very difficult. So we tried to insert a buddy wire, but it could not go beyond the distal tight lesion, and a 2-0 semi-compliant balloon could finally be advanced to the mid-RCA after a lot of struggle, but it failed to open up the lesion. As expected, the IVUS catheter could not go beyond the distal lesion, so a pullback was done from the mid-RCA. The vessel size was very big, with diameter over 5 mm. It was heavily calcified, and the calcium was superficial and circumferential, with a calcified nodule over the proximal part of the RCA, close to the tip of the guiding catheter. So what should I do next? Should I change the guide? How about using an Eeckhout AL1? But Eeckhout means I need to get another access from the groin as I was doing the procedure transradially. How about increasing the inflation pressure or use some other high pressure balloon, as the 2-0 balloon was only inflated at a low pressure? But there is always a risk of dissection, which may affect our choice of plug modification technique if needed later. So different societies have different treatment algorithms and flow charts, but the idea is basically the same. Take this as an example. For uncrossable lesion, you should consider upfront nephrectomy like rotor ablation. If you are able to pass an IVUS or OCT catheter down, then you can have more information on the severity of calcium, like the thickness, the length, or the arc of calcium. And then you can decide how to modify the plug by using NC or scoring balloon or OPN balloon or some other plug modification devices. So in my lab, the most commonly used device, apart from NC or scoring balloons, are IBL, rotor ablation, and orbital nephrectomy. So we try to do IVUS, but the catheter just could not get across the lesion. So we have to choose the device based on the angiogram and the characteristics of the individual devices. The lesion was so tight that the passage of 2-0 balloon was already very difficult. So I don't think I can deliver a shockwave balloon, and this option was out. For rotor ablation, we may need a big burr to get an effective ablation area, which means we may need to change the vascular access and upsize the guiding catheter. And it may not be a good choice to treat the calcified nodules. So how about combination like rotor shock or rotor gypsy? But because of some concern on the cost, an orbital nephrectomy device was used in the end. First, we would like to exchange a regular wire into a wiper wire using a microcatheter, but the distal lesion was so tight that even the microcatheter could not cross. So the tip of the catheter was just kept proximal to the lesion and to negotiate the wire carefully into the distal lumen. So the plan was to do a low speed and then high speed orbital runs in the proximal and mid RCA, and then using the guide assist mode to bypass the tortuous band to avoid any deep cut or dissection, and then to perform another run in the distal RCA. But after several runs in the proximal RCA, the patient complained of chest pain. Blood pressure dropped to around 80/60, and the ECG showed ST elevation over inferiorities. So I immediately withdrew the ground back into the guiding catheter and tested with some dye, and the flow to this RCA was actually blocked. So what should I do now? Should I do nothing, just wait and see and hope the flow will return back to Timid-3? Should I give any drug while waiting, like intracoronary vasodilator, adrenaline, or antiplatelet agent like 2B3A inhibitor? How about thrombus aspiration if you suspect there is thrombus? Or should I take out the orbital device and insert an IVUS catheter to see what happened? Can IVUS give you the answer? Or just ignore all this and continue with the orbital nephrectomy and to finish the procedure as soon as possible despite the chest pain and hypertension? So is there any suggestion from the floor, from the panelists?
I thought maybe we can ask around the panelists, see what would be their suggestion. Paul, are you still there?
Yeah, Michael. I mean, yeah.
What would you do? Yeah.
Not uncommon, right? I mean, I thought orbital was supposed to have less no reflow phenomenon because you're actually not occluding the vessel. But I think with those who've done it, I don't think by that. You know, I think orbital and rotor are just as likely to get this kind of situation. Sometimes it's just microdistal embolization, you wait and you get better. But I think if while you're waiting, I would get some drugs prepared. I will also double check that your ACT is in the therapeutic range. I think in a situation like this, if you don't get the flow back, sometimes a distal injection of adrenaline or adenosine, depends what you like to use. But I think when your blood pressure is already tanking, your heart rate sometimes can drop, then it's a very small dose of this distal adrenaline sometimes just get the flow back and you should be back in safety.
Eric, yeah.
I exactly wanted to say exactly the same, Paul. That can be a life-saving act. We let him, because I think it's a very important complication we show here. The first point, of course, we know to know what's going on. What is the diagnosis? Paul, you highlight no reflow. It's probably the case, seen the context. But of course, in the questions and the points you highlight, you also mentioned thrombus. So is there anybody having another opinion here in the room? Somebody thinks it's thrombus, somebody... We are a little bit behind schedule, so we have to keep it short, yeah? Yes, sir?
Hi, this is Dr. Rajesh from India. This is a slow flow, no flow situation after the orbital atherectomy. I would not continue the orbital atherectomy. I would rather pass a microcatheter in and deliver the GP2B inhibitors or vasodilators, establish flow, and then continue orbital atherectomy at this point of time.
Okay, that's a good point.
Okay.
Anybody else in the room?
Show us. Oh, okay.
Yeah. Go ahead.
Okay, maybe I'll just go on.
Yeah.
So there's lots of ways to deal with the situation, but different causes of low reflow would require different treatment. For example, you can give nitrate for coronary spasm. You may need to stent a flow limiting dissection. For thrombus, you can do aspiration or give medicine like 2B3 inhibitor. So the management is literally dependent on the underlying cause. But what's the cause of our low reflow? We've just checked the ACT, which was well above 300 seconds, which made the cause due to thrombus formation less likely. And on the angiogram, we could not see any obvious dissection. So here's my theory. During atherectomy, it's inevitably that some debris will be created in the proximal lumen. So the recommendation for orbital atherectomy is to limit the time of ablation and to give some time for the vessel to take some rest in between the runs in order to lower the risk of low reflow. However, as you could remember, even the microcatheter could not get across the distal lesion. The lumen was so tight that the debris could not get through, and eventually it was blocked, causing the low reflow phenomenon. This is just like the case the flow of river stopped when there is a landslide in the downstream blocking all the flow. So with this in mind, giving intracoronary vasodilator may not help the condition, and the only way is to open up the distal lesion as soon as possible with some form of mechanical methods. But the challenge was we were in the middle of the orbital atherectomy procedure, and with a very tight distal lesion, bringing a balloon down or microcatheter down was literally impossible. So what I did was to bring the crown down for further atherectomy. But because of the tortuosity, even with the guide assist mode turned on, the catheter could not simply get past the band. Instead, we had to do another round of orbital atherectomy at low speed to the tortuous band at the mid-RCA. And by doing this, the crown could finally reach the distal RCA, and after a few runs of atherectomy, the RCA regained TB3 flow, which somehow confirmed our hypothesis that the cause of low reflow was due to blockage of the lumen by the debris. But the rest of the procedure was straightforward. After that, tradition was further pre-dilated by high-pressure balloons, and this was the final result of the standing of the RCA. So PCI to the LD was performed 2 weeks later. It was not an easy procedure either. The mid-LD lesion was so tight that after wiring there was low flow again, but this time the patient was stable, probably because of the previously treated dominant RCA. So we quickly opened it up with a 1-node balloon and gained some flow. I first could not cross again, and because of the relatively narrow LAD, we chose rotablation. Sorry. So we chose rotablation with a 1.25 per, and then an NC balloon could be opened quite nicely. And this was the final result for the LAD after stenting. So the progress of our patient was quite uneventful. He was given a course of cardiac rehab during his stay in the hospital and discharged the day after PCI to LAD. Echo was repeated before discharge, and the LV function was nearly normalized. Clinically, he was asymptomatic with low chest pain and low heart failure symptoms. So ladies and gentlemen, I presented a case of acute coronary syndrome with heart failure, and the core angiogram showed diffuse disease and heavy calcification. Coronary artery calcification remains a major challenge to PCI, which may result in higher risk of suboptimal stent deployment, angiographic complications, and adverse clinical outcomes. Its management requires a systematic approach, and the use of plaque modification devices is essential, like rotor ablation, IVL, or orbital nephrectomy. But complications do occur, and the management will depend on the underlying cause. Just like in our case, we are using the orbital nephrectomy to treat the low reflow in the RCA. Thank you very much for your kind attention.
Well, thank you, Ivan. That's a great case showing how you manage the heavy calcification of both vessels, I would say, very effectively and very nicely done. Congratulations. I think, I don't know, it takes a lot of guts to pass down orbital atherectomy when you see this no reflow. Can you tell us how you manage the patient's hypotension and chest pain before you proceed? Because it takes some time for the OAS to get to the distal part and then open up the vessel. Do you need to do something first?
Yeah. Thank you. Actually, the chest pain was not very severe. The patient actually complained of mild chest tightness, although the blood pressure is quite low. So actually, at that time, we give fluid bolus and also put on dopamine infusion. Blood pressure is around, I can't remember exact figure, but around 90 something, just below 100. So because the passage of balloon and also microcapillars was very difficult, so I think we not worth to try pass the balloon again. So what we can do is to try our best to open up the lesion as soon as possible, and this time using the orbital nephrectomy.
Okay, but that's a great save. Thank you. Do we lose Eric? Eric, are you still there?
We are still there. We just realized that you were right and we were wrong, and that great case. Thank you.
This is unusual, isn't it? I know the distal lesion is the debris kind of microns in size, right? At least that's what the literature say. So while I understand the theory of plowing the dirt and get trapped distally, usually it's not the case, right? And I'm just slightly concerned that when you can't see any flow distally, to put the burr down even further, it just, I mean, obviously it is the right thing to do because you managed to get the flow back, but I'm just not sure I have the guts to do that. If in the road, let's say we do commonly do road ablation, and when you don't get flow distally, most of us probably won't drive the burr further down and burr distally again. Maybe it's just me.
Yeah, one thing you could have done, use a dual lumen catheter and just inject a little bit of dye more distal. But definitely, I think you made the right decision because I think the issue was there to some extent. Do we go to the last case?
Okay, I think we should move on. Thank you, Ivan. Thank you again.
Yann, do you want to bring in our last speaker?
Okay, sure, yeah. So last but definitely not least, we have Dr. Sim Hui Wen, who's from the National University Hospital in Singapore. And she'll give us her talk, which I think is entitled, What Goes In Must Come Out. Please, Hui Wen.
Hi, everyone. Hello, can you hear me?
Yes.
Yep.
Okay, all right. I'm Hui Wen. I'm one of the interventional fellow and consultant cardiologists from the National University Hospital and Ng Teng Fong General Hospital in Singapore. And today my talk is What Goes In Must Come Out. So just a brief introduction about the case. It's a 62-year-old lady. She has hypertension, diabetes, hyperlipidemia. She came to our A&E with a sudden onset of chest pain, shortness of breath, and sweating. And her blood pressure on presentation was a bit borderline, 108/72 and heart rate of 84. An ECG was done immediately and it showed as the elevation over the inferior leads. So confirm our diagnosis of an inferior STEMI. So we went on and proceed with the primary PCI to the RCA. So we inserted a right radial 6 French slender sheet and injected some 200 microgram of GTN as a routine practice. And we use a guide, a 6 French Icari left 3/5 guide catheter. And because there was some resistance with the usual 035 wire, we did a short of the radial artery. There was no severe spasm, so we changed out with a Terumo glide wire and proceed to advance our catheter. However, we did notice that there was some tightness during the advancement, but we managed to get it to the aortic root. So we performed primary PCI to the proximal RCA. So we haven't cannulated the left artery, we decided to just proceed with the culprit vessel first. So this was pre-dilated with a 2015 semi-compliant balloon. And then we implanted a 3048 mm drug-eluting stent and post-dilated with a 35 non-compliant balloon. This was the final result, which is satisfactory, and there was some distal disease, and you can see that there's some collaterals to the left anterior LED and the circumflex as well. And then we quickly swing our catheter to the left side, and this was the angiogram. We show very severe disease. There was a occluded LED and also a occluded, very diffusely diseased circumflex as well. So is this the end? Of course not, because this is a complication session. So as we were trying to remove the catheter, there was resistance, and we were unable to pull it out from the arm. That was due to a severe radial artery spasm. So what did we do? We injected more GTN via the guide, and we sedated the patient heavily with midazolam and fentanyl. And also, we gave some papaverine to the patient to vasodilate, and use tension, gradual tension, and try to pull back the catheter, but it still failed. So this was what happened to the catheter. We realized that after pulling with constant pressure for a while, there was quite a long length of the catheter outside the arm. But when we did the imaging, we saw that the catheter is still stuck at the axilla area. And then when we look at the catheter, you can see that this is not the actual catheter that was used, but I just reproduced it to show you that this is the Icari catheter, and you can see that this is the normal segment, and this is a segment that is near the end of the catheter. And because of this pulling, it causes the braiding to unravel, and also you can see the coating is stretched and denuded. However, the catheter is not fractured. And we try to inject, contrast and drugs through the catheter, and you can see that actually there's leakage of contrast and leakage of fluid through this segment that was elongated. So next, we actually call in the vascular surgeon at this point of time. So they came in and then they helped us to guide us what to do. So we did a DSA of the artery, and then this was what we found. As you can see, this is at the forearm. This is the radial artery, and then it actually went up all the way here and here. So the radial artery this is what we call as a high origin of the radial artery, and also known as a brachial radial artery. So to illustrate this in detail, you can see that the usual origin of the radial artery is actually at the cubital fossa. And in this patient, he has a very high origin of the radial artery at the axilla level. And this is actually, patients with this are actually prone to radial artery spasm. So what to do next? Do we keep giving more GTN, give more vasodilator? The patient's BP is a bit on the low side as well, so we're not so daring. Would you put the patient on GA or get the patient some regional nerve block, or call the vascular surgeon for surgical retrieval? Or anyone has any other tricks that they have to help with this situation?
Does anyone want to? That's a very brave case. We are all impressed on what's going on. The pain the patient is suffering, or how with all the drugs he got, he's more or less okay, or?
She was having pain, but because she was heavily sedated, so after that it was not so bad.
Okay.
I have come across one case like this many years ago when I was working in UK, and we got the anesthetist in and did the nerve block. And once it's done, the catheter came up, no problem, pretty straightforward. That might be what I would do. And it's interesting. Last time when I was in ECC, I think my fellow presented a case of a fractured guider, and that was also IL-35. Maybe there's something about two-remote guiding catheter you have to be more careful about.
You can try to stretch a catheter. It's actually quite easy to stretch it. You just use a bit of force.
Yeah.
So,
okay,
are there any? Sorry, maybe ask people here in Lausanne if anybody wants to make a comment, has an idea, because we are. Yeah, can we have the microphone? Maybe tell me where you're coming from.
Ahmad Seral from Lebanon. It's a tough case that we may encounter, not as uncommon as this. One trick, I think here it's a nerve block that may solve the issue. One trick to say about if it was a guiding catheter, it's very effective to put a long diagnostic catheter inside a 5 French and 6, and then the shaft of the catheter will be more strong, and you might be able to take both the catheters out, because with the guiding it's possible. If this was the diagnostic catheter as I see, I think you have to call the anesthesiologist for a nerve block here.
Eric, just suddenly think about this. In theory, if you're worried that the guiding catheter might just elongate, in theory, put a 2 mm balloon or 2.25 mm balloon inside the tip of the guide and give you a little bit more strength to pull it up. And at least at that point, the guiding catheter shouldn't continue to elongate. But just a thought.
So we're curious to hear how you solved the problem.
Okay. So what we did next is we consulted a very intelligent doctor, Google, and we found this article, and there was a case report that someone used Rotaglide to relieve the entrapment of the catheter. So based on that case report, that was what they did: 10 mils of Rotaglide in 500 mils of heparin saline, and then you slowly infuse it through the guide catheter for 5 minutes, and use another small syringe, like a lower lock syringe, and you purge through the radial sheath. Because it's quite tight, so you can only purge a small amount of Rotaglide through the radial sheath. So after 5 minutes of Rotaglide infusion, as you can see, we were able to pull the catheter back a bit, but nothing beyond that. So we infuse it a little bit longer, and we purge the Rotaglide through the catheter and through the radial sheath, and you can see that finally we managed to remove it. So this was the repeat angiogram. Initially, we were worried that there was some looks like perforation or something, but subsequently, after a while, we repeated another one, and it looks okay. And this was the arteries at the axilla, which looks fine as well. So after that, the patient was put on close monitoring of the uplink. The pulse remained intact. There was no compartment syndrome, no hematoma, nothing at all. Repeat angiogram showed that the EF was 50%. The patient was referred for CABG because of the severe disease, the left coronary arteries, and also distal RC as well. So just a short note on radial artery spasm. It's one of the most frequent trans-radial access challenge, but entrapment is rare, occur in less than 1% of radial artery spasm. This is because radial artery has higher vessel reactivity due to abundance of alpha adrenal receptor in the adventitia. And if your patient has like radial artery anomaly like this one, a high origin of the radial artery, or like female with small artery, you keep changing catheter, and patient has severe pain during the cannulation, then that's risk factors for a radial artery spasm. And this is the Rotaglide that has saved us. These are the ingredients that's inside. Probably has helped with to dilate the blood vessel. and act as a lubricant. And there was another, there are other case report that says that they use Viper's slide as well from orbital atherectomy, and it is also useful. So the algorithm for start radial catheter, I think first thing is not to panic and do a slow gentle pull. Subsequently, you can try to sedate the patient or use GA and inject vasoactive drugs through the guide, and then you can try to inflate the PP cuff also in the arm for 2 to 5 minutes. And you can try warm compress, external injection of like lidocaine and vasoactive medications. Otherwise, you can use Rotaglide or Viper slide and nerve block, and the last resort is surgical excision. Of course, you try not to avulse the radial artery while doing all this. So take-home message is that severe radial artery spasm causing start guide is rare, but it's preventable. So importantly, careful pre-procedure planning. So if the patient has like high risk of radial artery spasm, maybe try to use another type of access. Use imaging to assess the size. And careful selection of hardware. If you use shorter hydrophilic sheet, it will help. Use smaller size catheter and try to use minimize catheter change by maybe just use one type of catheter. And judicious spasmolytic cocktail. And Rotaglide can be effective in treating severe radial artery spasm. And sometimes you can go to Google for help as well. Okay, that's all. Thank you.
That's great, Hui Wen. Okay, we have one comment from the audience here in Lausanne.
Yeah, the important thing in a radial artery spasm is to prevent it. See, the problem with the cocktail which you gave was nitroglycerin. Nitroglycerin is a very mild vasodilator. We give in our lab nicorandil or papaverine as a spasmolytic cocktail. And when you notice you had resistance when passing the guiding catheter, it's important to take a shoot and see what's going on. If you have a very high radial artery or rigid, it means that radial artery is very small, and you should probably avoid this passing the catheter through this radial artery or take a femoral access. So important thing in radial artery is to prevent spasm rather than have a problem after you get a spasm.
Okay, that's a good point. There are some comments from the online attendees, so I think it's important to read them out. So there's one anesthetist and an anesthesiologist who's really basically echoed what Paul was saying earlier. They think that they are, if we had done a regional anesthesia of the plexus axillaries, then we would be able to resolve the spasm. So that's for the nerve block, I guess. There's another comment that they said they would consider injecting subcutaneous or intradermal ultrasound-guided GTN. I personally have no experience on that. I don't know if anyone does. Subcutaneous GTN. And finally, there's one that says, just use a BP cuff, a blood pressure cuff, to inflate several times. Then you can pull back the whole catheter. Again, I'm not sure about that.
That's the flow-mediated dilatation. Sometimes we do use it, but I tried it before and it wasn't really particularly helpful. Hui Wen, just I know be sure you are infusing the Rotaglide in the radial artery sheath or in the guide cath?
Both. So through the guide, and also you use a small syringe through the sheath.
But I thought you were saying that when you were injecting it, you were leaking. Whatever is sticking out, was it?
Yeah, but not everything is leaking out. Just like leaking part of it. Yeah.
One comment here from Lausanne.
Very brief. I've done all of those except the nerve block. But one thing that works frequently is massaging, which probably works as the vasodilator in the whole arm, wherever the patient says it's painful. And it helps a lot because it probably releases any vasodilating properties of the endothelium. But mostly I change to 5 French.
Okay.
Maybe the leakage from the catheter in this case is good. Because the vessel is tightly wrapped around the guiding catheter. So any drug that is delivered through the tip of the guide would actually not reach the artery. So maybe the kind of leakage from the denuded catheter actually helps to deliver the lubricant to the artery.
Infusion catheter.
That's called a half glass full approach to life rather than a half glass empty. Okay.
Maybe for the European or colleagues at least, you should know that verapamil is standard 2.5 5 milligrams before starting a radial, but to my humble knowledge, in Asia it's not done. No? Verapamil, Isoptin.
I use
I give it, but not all my colleagues do. So for my cocktail, I have heparin, GTN, and verapamil. But the verapamil is not for everyone. Yeah.
I think, Eric, this is an inferior MI case. You know, verapamil sometimes give you a lot of rhythm problems.
That's right.
We even sometimes give verapamil. We have a radial approach in a TAVI, so which is also to be discussed. Not everybody has rotaglide, so I wonder if you have propofol, would that work?
That's what I'm going to say, Eric. We at the start of our TAFI program, we used to put propofol on our sheaths so that it will actually enter very, very nicely. But I don't know whether propofol is readily available. I think it's sort of a dangerous drug, which is not really readily available in our cath lab anymore. But it works well. It's a lubricant.
Yeah. Okay, I think we are at the end of the first session. We would like to thank, obviously, our speakers from Singapore and Hong Kong for presenting very excellent and very a diverse range, I would say, of complications and cases. I think everyone here learned a lot. So special thanks again, a special shout out again to the cardiac societies, the Singapore Cardiac Society and the Hong Kong Stent Society. And this session also was supported by the Asian Pacific Society of Cardiology, APSC. So on behalf of the panelists and on behalf of Eric here in Lausanne, we would like to thank everyone for your participation in this first session, and we will bring it to a close. And for the attendees who are here physically, you can visit the exhibition hall and grab a coffee and visit the exhibits. Our next session will resume here at 3:45 p.m. Thank you.
Thank you. We have to join in Lausanne next year.
Yep, something to look forward to. See you guys.
See you.
Bye-bye. Thank you.
Bye-bye.
Bye. Take care. Bye-bye.
welcome everybody to the next session. It's our privilege to be panelists, Tito, Kabir, Brahim and Alexis. Eric assures me we've got some excellent cases coming up. I'm sure they're going to spark conversation. So first up we have Geraud Souteyrand from Clermont-Ferrand in France. Thank you.
Thank you very much. Thank you for the invitation. I will share with you a very interesting case, which the name is it a normal diagnosis coronary? So it's the story of a very young woman of 61 years old. She suffered of chest pain from 1 year, and she was addressed for diagnosis coronary. You can see the right coronary without any disease. It seems the same with the left main and LED, and she came back home without any treatment. But 1 week later, she came in our institution, in our emergency room, because she suffered at rest from a chest pain during 1 hour. The EKG was not modified, but there is an elevation of troponin with a good ejection fraction on TTE. So what's your opinion at this point? We didn't have any images of the first coronary, so we asked the first operator by phone, and he said that there was a doubt on the angiogram about the last injection in the left main, and the patient said that she has pain from only 10 minutes, 1 hour after the first exam. So what do you suggest at this time? Do you perform a new coronary? Do you perform a CT scan? Do you stay at medical therapy? Another suggestion?
Well, maybe ergonovine testing for a vasospasm?
Yes, it could be a good option by coronary or?
By coronarography, yes.
Yes, okay.
Okay.
Well, I always start by reviewing the previous angiogram, and it looks like left main is too small for the 2 arteries. So I wonder what's going on at the left main.
Okay. So you perform a coronary at this time, yes? CT scan, yes? Okay. So because of the discussion with another colleague, we decided to perform a CT scan. I will show you the result. And on the CT scan, there is a big haziness in the left main, and there is a doubt about an hematoma on the left main that you can see here. And here you can see on these images that there is a big haziness of the left main. So we were very in trouble because she was very young. And what is your management of this patient at this time? Do you do a surgery, angioplasty, medical therapy with the goal that the hematoma will disappear during the time? Do you have any another suggestion?
Okay, should we take a straw poll? Who votes for surgery? So this
one, only one, yes.
This being an interventional meeting, we have one hand. Okay, angioplasty? Angiography? Okay, so I think there's an overwhelming majority of the people. Anybody else, medical therapy or another way? Yeah, I think we all agree that that's probably not going to be successful here. So tell us, what did you do?
So we agree. We thought that for surgery it was not a good option because the bypass will involve in the future. That's why we decided to try to do a new coronary, very careful with caution, with a catheter which was not inside the left main. And you can see that there is no doubt about the dissection of the left main with a big hematoma of the left main. So do you perform angioplasty at this point?
So just Geraud, this is guiding catheter, 6 French.
Yes.
What kind of guiding catheter?
It's a 3.5 GL, and we do the first injection outside of the left main with a guide wire inside to be very careful to go inside the lumen. Yes.
Can you hear me now? Yeah. Well, I mean, you can't. You have to get some caudal views to assist the bifurcation, the left main, and I mean, just cranial will not be helpful here. You need some more images to show us to decide. But I think caudal will be more helpful. Second thing, I think the main problem was in the first diagnostic that the diagnostic catheter was very deeply engaged and was actually hitting the roof of the proximal LAD, so I'm not surprised that you had dissection. But with these two cranial and difficult, they're caudal, I think it's difficult to suggest to guess, but I think you proceed with PCI. If I can see more images at least to analyze where we're going to understand and how is the bifurcation looking.
Yes, and for the different ways, it was very difficult because there was a superposition of the of the LED and the sub branch, and that's why the best view was on OEG at the right part. But it was very difficult to go in the sub branch with a wire. It was very easy to go to the LED. I will show you in the next view. And you.
So the other thing that you can just do some imaging here. And this will give you some more information.
Yes, you will see. So I will show you the progress of the wire in the sub branch because you have seen that there was very difficult to go inside the sub branch, and we perform images to be sure that we were inside the true lumen with the wire. So I will show you in the. So it's a pullback from the distal part of the third branch to the left main. You can see on the proximal part of the third branch that there is a little atheromatous plaque. You can see just here with the antima, and there is an hematoma on the left main with a tight stenosis due to the hematoma. I will show you on the different part of the pullback. You can see on the distal part of the pullback that there is no disease, but when you go in the final part of the pullback, you have the tire of the catheter, which is the engagement of the catheter is that's why there was an hematoma. And we be sure with the pullback that we are always in the good lumen. That's why we go to the angioplasty. So the next step was to treat at first the sub branch because it was the more difficult to go by the wire. We could discuss about the strategy, and after we treat the LED with a stent from the proximal part of the left main to the LED. After we perform a pot and we recross the sub branch to do a kissing balloon. But it was very difficult to recross the sub branch. There was a hemodynamic instability. The patient has 40 millimeter of mercus. And just after recrossing the sub branch, we could only cross with a balloon of 1 millimeter of diameter. And after the crossing of the sub branch, the hemodynamic was was better, and we could go with kissing balloon. The angiogram just after the angioplasty found that there was two problems on the angiogram with haziness in the ostium of the third branch and in the LED just after the stent, but it was no disease on the first angiogram at this point. So do you think it's thrombus? Do you think it's already a dissection? What is your...
Okay, so I think we have a question here. And
I mean, why did you adopt a strategy to stent first the LED I mean, you're dealing with dissection, so recrossing to that circumflex will be a nightmare. So basically, why don't you just put you have 2 wires secured, 2 arteries. So you put a stent in the circumflex with 1 millimeter to the left main, and then just stand the LAD and just do then kissing. I think that would be a better strategy. The trouble here, if you just try to cross the circumflex in a dissection scenario, it will be a nightmare. So you can just do what we call like mini crush with 1 millimeter stent mesh in the from the circumflex to the left main, and then the beside the LAD.
There is one more comment here. Yes? With the microphone, I think. Yes. Use the microphone.
This was clearly a separate origin of the LAD and circumflex, a separate origin. And you had dissection the circumflex. I didn't understand why you stented the LAD first, not a circumflex.
No, we stent the circumflex first.
First.
At first, we begin with the circumflex, and after we go to the left main to LAD. Okay. We begin with the circumflex.
Yeah, I think you did exactly what I think the colleagues were suggesting.
Yes.
You
Yes.
secured the circumflex.
I show
first.
you one more again. The beginning of the procedure, it was the circumflex.
Yeah.
And after we go to because it was the more difficult to cross with the wire. After we stent the LED to the LED, to the left main to the LED, and after we recross the wire to the circumflex for the kissing. And at this point, it was very difficult because after the stenting of the left main, the hemodynamic was not stable. Okay, but at the beginning of the procedure, it was a suck branch which was stented. Okay, no problem. We have exactly the same meaning, but we thought that after the angioplasty, the result was correct, but there is the 2 azinettes. That's why we perform again OFDI, and you can see that on the LED, it's not a thrombus, it's a dissection. On the LED, and we will show on the final part of the pullback that there is thrombus in the left main. That's why we stent the LED on the middle part. You can see here that there is a big dissection. And after the stenting of the LED, it was much better. You can see that there is no dissection just after the stent, and there is only still thrombus. And you can see on the ostium of the suck branch that the result is not perfect. But the patient at this time had no pain. She was stable. That's why we decided to treat her medically. You can see on the ostium of the suck branch that it was not perfect with the thrombus. We decided to treat medically and to control her at 1 month. During the time, we received the first procedure of the diagnosis coronarography, and it was the last angiogram. And you can see that, as you said, the catheter was very deep in the left main, and that's why there was a dissection. It's amazing, but the patient had no pain, only one pain during 10 minutes, 1 hour after the angiogram, and she suffered only 1 week later with the elevation of troponin. It's amazing. So the evolution was favorable. We decided to control at 1 month with a good angiographic results that we confirm by OFDI. You can see here that there is no thrombus on the distal part of the LED with good expansion of the stent. And you can see that the opening of the struts in front of the suck branch are perfect, just here in the left main. And there is maybe only few malapposition, but we are in the aorta wall. Here you have the result of the OFDI. And there is no thrombus in the left main, and with a very good result on the suck branch. The CT scan control was already perfect without any dissection on the left main. So in conclusion, we have to be always careful for the tip of the catheter during the injection, and we should listen the patient when they say that they have some pain just after the coronarography. I think that OCT is a good tool to help us during iatrogenic dissection to treat it and to be sure that we are in the good lumen. And I think that a CT scan could help us. In this case, it was very interesting to know what was the complication, because when we go to the angioplasty, we were aware about the complication. Thank you.
Thank you, Geraud. So we have some questions.
Hi. A very, very nice case. Why OCT or FDI versus IVUS on an osteal lesion and dissection?
Yes, it's a good. I think that the both tools are very good for to be sure that you are in good lumen. In our CT, we perform more OCT than IVUS. We don't have IVUS in our cath lab, so that's why we use OCT. OCT, I think it's better to be sure at the end of the procedure that you have a good result with the stent. But
to be clear, Geraud is one of the top experts in OCT in France. He's doing one of the biggest volumes, and he's having an OCT course every year. Is correct?
Exactly.
And I'm impressed by your case. The images of the initial angio, that's amazing. Did you communicate with the operator? How did that go? How is the patient doing? Is there no issue with legally with this case?
Yes, but we were very surprised because the result of the coronarography was a normal coronarography after this, and when she came with later after the exam, we for the first opinion we said it's nothing, you can go home because you have a normal coronarography 1 week before. And I think that we have to be very aware to see images, because it was not right that there was a trouble during the procedure.
Okay, one question here.
Great case, and I have a particular interest in imaging as well. And I think you showed that we can use OCT safely, even in the context of a dissection, and in particular in a short left mean, and you still managed to get a very good images. I just want to add a point. Like in your case, we didn't see the proximal edge of the stent. Yeah, it's in the aorta somewhere. We don't know how much is protruding. I think just as a tip, when we are doing OCT and we're trying to assess the ostium of the RCA or the ostium of the left main, we can use a guide extension catheter, like a guide liner or a guidezilla. Just put the distal about 2 millimeters of the guide extension in the ostium of the left main, back out your guider, and the OCT can penetrate through the distal 2 millimeters of the guide extension. So that allows us to get good contrast clearance, as well as still be able to assess the very ostium of the artery, the RC or the left main.
Yes, I've performed two cases like this with the left main and the right coronary artery in case of ostium lesion.
And as an extension of this, you can use a smaller guide extension and a sentinel wire, so you can define the ostium at the end of the guide catheter, and use a smaller, say a 5 French guide liner into the left main to get the best of both worlds. Do we have any other questions?
Maybe. Do you usually do a CT scan afterwards, or did you review the images and then thought maybe there's something on the left main and you decided to do the angio CT?
No, in our center we perform a very few CT scan, and it was before, because I didn't have the images and my colleague said that there is a doubt, so I thought that it could be a good option to not to go far with coronarography without any any notion of what could be happen. That's why we do the CT scan, but usually we don't do a CT scan.
Thank you.
Thank you. Ivan Núñez from Madrid.
Okay.
Congrats on the great save, man. In this case of anterograde dissection, you perform nicely the OCT, but I agree with you that probably I will vote for the IVUS, an IVUS co-registration, because when you have an anterograde dissection, sometimes I think it will be nice to try to avoid any contrast injections to avoid the extension of the dissection or the hematoma. You already have the images of the CT scan, which I think is a safe thing to do. But anyway, OCT and IVUS are a very good thing to do.
Yes, I totally agree. We have a big experience in my city with the spontaneous coronary artery dissection that we manage with OCT, and that's why we were very confident with this tool. But we didn't have any. What we were afraid is the extension of the dissection during the angiography, but we didn't experience that, and I think that it's sometimes with IVUS, it's very difficult to be sure that you're in the good lumen, but IVUS progressed for the last year, so I think it's better now than 10 years ago. And 10 years ago, when we began with OCT, it was better than IVUS to be sure that you are in the good lumen.
Thank you. Great rescue. In fact, I want to have your experience in Clermont about spontaneous coronary artery dissection and OCT. Do you have to? It's necessary to have the wire in the true lumen to get the OCT, or is it safe also if the wire is in the false lumen? Or you have to have the wire in the distal true lumen before performing OCT?
I have a very interesting case with the lumen, which could go in the true lumen after in the false, in the true. And in two cases, we had the wire in the false lumen, and we could go with OCT in the true lumen after. So we perform OCT in the both cases, but there is no aggravation of the patients.
Is there another question?
I just wanted to say that sometimes people criticize interventional cardiologists, but you saved the life of this patient. If you wouldn't have been there, the patient should have passed away. Mm.
Can I ask, just out of interest, in the very first angiogram that you showed, the left main looked very much smaller than the distal, the two branches. Was that your first image or the original operator's first image?
It was the operator's first images.
So do you think that there was already a dissection at that point, or there was some pre-existing disease, or it was just that the guide catheter was too deep?
I think that the dissection was in the very in the last image, because we didn't have the haziness of the left main on the first, and in the last, I think that the catheter was deeper in the left main, and at this time that was the dissection.
So she should have had a CT to start with.
Yes, exactly.
And it's amazing that the patient accepted to repeat the CAT for the control 1 month later.
Okay.
Thank you very much.
That's a great case. So shall we move to our next speaker? So we have Fatih KAHRAMAN from
Turkey.
From Turkey. Apologies.
Yeah. Hello, everyone. Can you hear me?
Yes.
I'm Dr. Fatih from Turkey. First, I want to thank the organizing committee to accept my presentation online. And if okay, I want to share my screen. Should I share my screen?
No. Can you share your screen, please?
Of course. Okay. Can you see? Can you see my screen?
Yes, it's
yes,
okay.
now it's okay.
Okay. If everything is okay, I want to say hello to all chairpersons and my colleagues in the auditorium. I will try to talk about my case, which we had 4 challenges in the radial intervention, and radial artery rupture, and radial kink, and anterior jamming, and subclavian tortuosity in only 1 patient. And our patient was 66 years old female, admitted to emergency department with chest pain persisting for 2 hours. And she was diagnosed acute inferior myocardial infarction. And after dual antiplatelet loading dose with ASA 300 milligram and 600 clopidogrel, she was immediately taken into cath lab. And we have planned right radial intervention for this patient. After inserting 6 French Terumo radial sheet, we tried to send 0.38-inch guide wire to the lesion, but the guide wire didn't go forward in the forearm level, and we took it back and we injected contrast to the radial artery via 6 French right guiding catheter, and we saw there was a very huge radial artery rupture in the forearm level. And you can see the video. Can you see the video?
Yes.
And there's a very huge radial artery rupture in this case. And if you were in my shoes, what would you do in this case? Would you compress externally with blood pressure cuff and contralateral radial intervention? Or would you compress externally and ipsilateral ulnar intervention? Would you prefer balloon-assisted tracheic technique and compress the lesion internally with guiding catheter? Or would you compress externally and turn into femoral intervention?
Okay, shall we take a show of hands? Who was in favor of external compression and contralateral radial intervention? I would say that's about 50%, maybe slightly over 50. Okay. External compression and ipsilateral ulnar? Yep, 0. Balloon-assisted tracking and internal compression? Okay. External compression and femoral? Okay, so maybe 20, 30%. All right, so it looks like there's a majority for external compression and contralateral radial, with some opting for femoral. So tell us, what did you do?
Okay, thank you. Thank you for your comments and participation. In this case, and in many of our cases, to overcome the situation, we passed the ruptured area and we used balloon-assisted tracking technique. First, we passed the ruptured area quickly with 0.14-inch floppy guide wire, and we took the semi-compliant balloon 2.5 to 15 millimeter into the 6 French right guiding catheter, and we passed the lesion with this technique. You know, in butt technique, half part of the balloon is outside the catheter and half is in, and we inflated the balloon into 6 atmosphere. You can see in this video, our floppy has already passed the lesion, and we can pass the lesion with balloon-assisted tracking technique. I think you can see it was very simple procedure to pass the ruptured area. And after passing the guide wire, we have some different choices about the managing of complication. For example, there are some choices here. I want to hear your answers. For example, after passing the covered stent, or would you just keep the catheter for 20 minutes in the area, or would you keep inflated balloon, coronary balloon in the lesion, or would you call vascular surgery to prevent compartment syndrome, or would you compress externally and just wait for spontaneous heal for maybe 10 to 20 minutes?
Okay, so who will go for A? B? Okay. C? D? And E? So majority for the B.
Okay, in our daily practice, we mostly prefer internal compression and go on from the same area to the interventional procedure. And after passing the ruptured area, there was also very sharp radial kink in the elbow level. Fortunately, we had already have floppy guide wire and balloon assisted tracking technique, because if there was a 0.38 guide wire, it would be impossible, nearly impossible to pass this 360-degree kink of the radial artery. And in this case, we could pass this area with butt technique also. And after passing the radial kink, I will show in the videos in the next slide, we changed the floppy guide wire with 0.38 guide wire in the axillary artery level. And you can see the first video. Butt technique is also very useful and helpful in radial kink, passing the lesion, passing the kink area. And in the second video, at the end of second video, you can see with the strong support of 0.38 guide wire, the radial kink resolved easily. And at the end of the video, you can see it. And then, after passing 0.38 guide wire, we tried to proceed our right guiding catheter. But in this case, in the axillary artery level, endothelium jammed between and squeezed between the guide wire and guiding catheter. You know, there may be some gaps. In the lower extremity interventions, we do not see these problems in our daily practice, but upper extremity vessels are small in caliber. We can see this complication or problem in our daily practice. So we couldn't proceed the catheter easily to the aorta. I want to ask you, and I wonder your approach. We forced it very much, but we couldn't proceed the catheter to the aorta. What would you do in this case? I don't have multiple choice questions, sorry, but if you have any comment or addition in this case, what would you do? I will be happy.
Just one comment, perhaps. How did you manage the pain of the patient? Did the patient have pain on the arm, or?
No. The patient doesn't feel any pain, but the guiding catheter does not proceed easily. We cannot proceed the catheter; it's stuck there.
Well, you could consider an exchange wire and changing to a 5-French catheter. Maybe, I don't know if anybody else has any suggestions.
Have you ever did an angiogram of our upper limb to make sure that you are inside the vessel?
We are inside the vessel.
Because you have just crossed the. See, you have, first of all, you have gone with the bad technique. I understood that, but as you cross the elbow up, you are still pushing the catheter with the balloon support. right?
Okay, it could, yeah,
which could have damaged again the vessel. Why you didn't think of just taking an angiography of the upper limb to make sure that you are inside the vessel?
Because we were sure.
Because anyway, you had a good dissection down. You had the dissection in the radial aspect, right? So you are sure that you are still in the true lumen or you are out of the lumen?
But our guide wire went easily to the brachiocephalic artery. We were, indeed, we were very sure we are in the right lumen. But we didn't think we are in the false lumen.
Okay, so it sounds like you were confident that you were in the true lumen, and that's why you didn't do an angiogram.
Yeah, we were confident. Yeah.
Sure.
One way is to take a glide catheter. There's a 5 French thermo glide catheter. You take it all the way into the aorta, then take a 035 wire, and then exchange your guiding catheter with that. That's the other way of crossing a difficult radial loop. You use a bat to cross the radial loop, but the other technique which you use a glide catheter, 5 French glide catheter crosses the loop. Then you use your regular wire to exchange the guiding catheter.
Yeah, seems like a reasonable suggestion.
Just one comment, as I mentioned earlier, you can put a long multi-purpose 5 French, 125 inside the 6 French, and then you can advance easily the guiding catheter. But in case of ST elevation MI, it will be very difficult to handle then the catheter for a diagnostic cat, or I would say straightforward. Here it's better maybe to change to another access.
Okay.
Or at any point you consider at this point to go femoral. I mean, like you can, to leave the guide catheter there, you can check from the femoral part that you have sealed the perforation with the guide catheter from the inside, and you can continue with the STEMI from the femoral approach.
Okay, thank you for all comments and answers. They are very helpful for me. But in this case, we inserted a second 5 French pigtail catheter inside the 6 French guiding catheter, and we have eliminated the gap between 038 guide wire and guiding catheter. And we could pass the area easily, and we reached the subclavian artery. And in the first image, you can see our guide wire is in the vessel, and our guiding catheter tip is here, and there is a small gap in this image. And in the second image, after inserting the 5 French pigtail catheter, it eliminated the gap between the two tools, and it diminished the gap, and it went easily to the brachiocephalic artery and proceeded easily. And we could overcome the situation with this technique, pigtail catheter, with the help of pigtail catheter, 5 French. And this is the last obstacle in our case. After arriving to brachiocephalic artery, despite many attempts, we couldn't pass into the aorta. We have used 2 pieces, 038 guide wires together to increase the support, or we changed it to 035 hydrophilic guide wire, but we tried it nearly 5 minutes, but it was very unsuccessful in this case. And you can see this video. It seems a very simple anatomy maybe from here, but it was very difficult to pass into the aorta for us. And in the last obstacle, we gave up. And we tried to turn into femoral approach. We pulled back the guiding catheter to the proximal part of the ruptured area for internal compression. We went on femoral approach and put a stent to circumflex artery. It lasted totally, nearly, it was a very simple lesion. It was a totally 10 to 12 minutes. And then after the finishing of the procedure totally, we took an image of the ruptured area by pulling back our guiding catheter to the distal part, but extravasation was still going on in the lesion. And you can see it was a bit smaller than the previous one, but it was still going on. And in this case, would you prefer external compression or again, what technique and pass the lesion and wait there, what would you do if you were in my shoes?
Can we have the mic, please? The microphone, please.
Do you hear me? Yeah. I think the first lesson to learn in this case is to try to keep it easy. Why you lost a lot of time to handle a very complex anatomy, and I think it isn't a good option to try and try and try. It's easy to take another access like femoral artery, and for this extravasation, you can do a covered stent.
So we propose a covered stent.
Can I propose something more tricky? At this point, the problem is that you have to recross the perforation again, and you might dissect or aggravate the perforation because you don't have a guide wire in place right now. When you finish the procedure, I might suggest that to go with the catheter from the femoral approach, to keep your guide catheter there, get a long hydrophilic wire, put the hydrophilic inside the antegrade guide catheter, then remove the antegrade guide catheter, just to have a guide wire inside the perforation, in case you might not go intimately afterwards antegradely, so to have like a bailout solution.
Many of these extravasations eventually seal off. Just by putting the guiding catheter in for a longer time, you should never put a covered stent in radial artery, for sure. Always it seals off after some time. If you keep the catheter in longer, it eventually seals off. We have seen number of radial extravasations, nothing happens.
Yeah, I mean, I would tend to agree that the majority of these extravasations tend to seal with this time, essentially. Maybe a vascular surgical opinion. So should we carry on? What happened next? What did you do?
Can I just add one comment, please?
Sorry, carry on.
Yeah, I mean, we are in STEMI, so basically the patient had heparin, had DAPT already, so this is also complicated the whole scenario. But the question is, if we know that there was perforation, why didn't you leave the wire already there and did a retrograde sort of like injection to visualize the whole arm vasculature from the femoral axis which he had? So why did you remove the wire already, which was in the radial artery? I think you should have left that and just did an angio from the femoral guide catheter, which is just the axis you had, and then it would be easy to deal with it with the covered stent there.
Did you hear the question?
Of course, but after the end of the procedure, we didn't predict the rupture is still going on. Indeed, when we took the guiding catheter, we were sure it will heal. It will be healed easily. You are right in your comments and answers. Thank you very much. But we suppose that it would be healed during the by the help of internal compression. So we were sure by pulling back the catheter, it would be healed.
Okay. What happened next?
And the next, we passed the ruptured area with butt technique again. It was very easy also. This is BMW floppy guide wire, past the lesion, and you can see the semi-compliant balloon again. And we inflated it in the tip of guiding catheter. And then we could have passed the lesion again easily. During the process, the patient didn't feel any pain in her forearm or arm. And we have passed the lesion easily with the same technique as I showed in the second video. And then we waited for internal compression for 20 to 25 minutes. And at the end of image, the extravasation was totally healed. You can see the last image of the procedure. The patient was free of pain. And this is the last image of our procedure. After finishing the procedure, we followed the patient in intensive care unit and cardiology ward for 3 days, and we discharged her in good health. In the first week and first month controls in outpatient clinic, she was very fine, and there was not any problem in her arm, and her radial artery was patent. If you let, this is my last slide. I want to summarize my case and finish it. And radial artery rupture may seem especially in high takeoff radial arteries, but in our daily practice, before insertion the guiding catheter or guide wire, we cannot predict this radial anatomy. We should be careful because while sending the guide wire, we should be very gentle and slowly we should send the guide wire. And the radial artery ruptures management, urgent management is very important for the safety of procedure and the patient. And someone asks in the auditorium, I agree with them, but why did you waste your time with your radial intervention? You should have turned into femoral artery. I agree with them. It may be a good option, but we couldn't predict the second, third, and fourth challenges, obstacles in this patient. We just try to heal the ruptured area and go on from the same site. So coexisting challenges in our daily practice, like this patient, is very few in number, as we know. But if they come all together, radial kink, radial artery rupture, and endothelial jamming and subclavian tortuosity, it may cause the case more complicated. And this case is a good example for the management of 4 challenging situations in one patient. And I want to thank you for your interest and patience. This is the last slide. Thank you very much for your attention.
Thank you very much for this case, Fatih. We have now to move for the next case with Dr. Nikolai Stoyanov from Sofia, Bulgaria.
Good afternoon. It's a great pleasure to be in front of you today, this afternoon, and to share this quite interesting for me case with you. It's the title is VIP Afternoon. Why afternoon? Because it was one nice Tuesday late afternoon. We were with the team. We were quite happy because we finished our program, and we decided to go home and to have some fun. But unfortunately, my boss came with another physician who is chief in another department, and he said, okay, my friend is here, and he has unstable angina since 2-3 weeks. Really unstable. Let's do it today, and he can go home tomorrow. We said, okay, it's our boss, yes. The ECG was normal, echo normal, normal troponins, and so on. And we decided to do it just fast angiogram and see what's going on and to fix it, and that's it. That's the angiogram of the left system. I have only this shot, and probably you can appreciate this tight lesion of circumflex. Probably it's not well seen, but it's quite calcified, really tight, believe me, really tight lesion of the circumflex artery. This is the right system, irregularities 30-40%. And of course, we decided to fix the circumflex and go home. My boss started, and I scrubbed with him to speed up a bit. And our setup was 6 French, EBU, as usual, 3.5 workhorse wire. And he tried to pass the lesion with 215 semi-compliant regular balloon, but the balloon didn't cross. I said, okay, let me try. a bit more aggressive with extension catheter and 6 French, guide 0, and I passed. I was almost there, but I have something as a dog bone effect of the balloon, and after that we lost the access. We were quite aggressive, let's say, and my first question is what to do next to stop the procedure. He's pain-free. We can schedule him for tomorrow or for next time to keep the same approach, to change the 7 French radial approach or femoral approach.
Okay, should we take a poll? Who would vote for number 1? Okay.
No one.
I guess nobody, but it had to be that. Carry on with the same approach? Okay, so maybe a third to a half. 7 French radial?
Okay.
Yeah, maybe a smattering. And any femoral backup? Yep.
Femoral.
One or
okay.
A few people. What did you do?
I have a second question. Sorry for that, but which technique do you want to use for this calcified, really calcified lesion? Balloon-based technique, rotablation probably, orbital, atherectomy, or IVL? Please.
Okay,
vote.
balloon?
Balloon?
Rotablation?
Tried balloon. Okay.
Orbital atherectomy? IVL? So it looks like rotablation with a close second with
what of opinions?
IVL.
Okay. I said, we discussed with the patient and his son. His son is a physician in the same department, and he stayed next to his father's shoulder, let's say, under the tube, and he tried to give him some support. Okay, they will deal with this, don't care, everything's going well. I said, okay. Okay, I will take my supportive guiding catheter, Amplatz left 2. I prepare everything for rotablation. The system, we have old one, not RotaPro, the older one. And I took microcatheter and feeder to cross the lesion and to speed up. But during the preparation, my nurse said something's wrong. The tip of the guiding is not there. I said, oh, okay, probably we were quite aggressive, and somewhere I said, oh, I don't want to see this tip in the head, and I did this fluoro to see guiding, yeah. I couldn't find it in the head. I said, what to do after that? Well, we discussed a bit with my boss. And what's your opinion? To no further examination and go for PCI? Stop the procedure? Whole body, fluoroscopy or CT scan?
Okay.
Sorry? The tip of the guiding wasn't there.
Was it crumpled or it was detached? How could you?
I don't know, detach. This.
Can we get the microphone?
This picture. How we lost? We pushed really hard, and the guiding went out. Yeah. Yep. Easy, as usual. Okay. And
sorry, can I just go? When you pull the guide catheter out, was it easy to pull it out? Because by the look of the tip, it's crushed somewhere, which is like calcium or something. It doesn't sound like it was in the coronary and just smooth. So there is something which crushed it. Did you pull it back easily, or was it stuck somewhere when you pull the catheter out? Was it stuck? Was it stuck actually in the axis, in the sort of like the radial axis?
I don't know. I checked the head and the arm, and it wasn't there. This is the sorry.
I think the question is our colleague is trying to ask is when it came out.
Yes.
Was it stuck anywhere, or it came out smoothly?
No, came out easily.
Okay.
With the wire, balloon, extension catheter, and guiding catheter. Unblock everything out, and probably no further examination. We did the same. No. It was no.
Somewhere else. Okay, so you went for option number 1, is that correct?
Number 1, yeah, of course. Is somewhere in the legs, I don't care. I'll proceed. It's a late afternoon, we want to finish the case. It's a VIP patient, we should do everything really correct.
So these are all warning signs, aren't they?
Yeah, it's a warning sign, yeah.
Sorry, can I
You're
add
still
1 point,
desperate
please?
to get home.
Sorry, can I add 1 point? Can I add 1 point, please?
Sorry, can we...
I mean, the only thing which could be that the balloon was still inflated, and somehow we're pulling the balloon and you crush the whole guide catheter together? I don't think.
No.
How would a piece of the guide catheter be fallen out? They're very stiff. You need a knife.
No, the tip of the catheter is not really stiff. It's really soft.
But
It's atraumatic. Yeah.
Yeah, but...
Yeah. Yeah.
I suspect we're going to find the other end at some point. Yeah. Okay. Should we? Do you want to carry on?
To go on? Huh? Yeah. Thank you. No further examination. I don't care. And I was there with my 7th French guiding. The microcatheter didn't pass. I directly took the floppy wire and 1.5 burr. And this really small injection, we lost the flow in the circumflex artery. And I did 1 run, 2nd run of the rotablator, and during the 3rd run, I lost the pressure. The speed decreased. I said to my nurse, please increase, go. But finally, I pulled out the burr, and I saw that I don't have any gas in the bottle. Some technical issues in Bulgaria. Okay. And what's next? I don't have the opportunity to change the bottle to continue with rotablation during this procedure. And this is my next question. How to proceed with balloon-based technique, stop the procedure, or some other plaque modification technique?
So balloon-based technique?
Sorry, have you recovered flow by now?
Have
you got flow?
Yeah, exactly. Have you, I mean, you still have the wire. Did you just see what happened after the rotablation? I mean, before we decide?
Yeah, I will show you.
Yeah.
Next,
but
that's what decides. If you have flow, I would go with the microcatheter.
Okay. There is some flow, yeah. There is some flow, and the patient is stable, pain-free.
And by the way, 2 images back, I felt the tip of the catheter was inside the LCX.
Okay.
I felt like that.
Yeah,
the
probably.
tip was just 2 images back. If you see it. No, before that.
Yeah, it's there in circumflex.
In the LCX.
It's still circumflex, yes. Before the first run of the, yeah, that's the point. You have a good eyes. Okay. And what to do? What to do?
Because of my eyes.
Because of experience.
I had 2 cases.
Okay.
I finished my RCA. I took the guiding out. I could not see the tip. I searched the whole body from top to bottom. I searched. Again, I saw the tip in the RCA. Next was LCX. I finished it. I took out the catheter. I didn't get the tip. I searched. At last, I got it from the LAD. So 2 cases I had. So.
Me too. I didn't see the tip, but it was there. Okay. Balloon-based technique. Who will proceed with balloon-based technique? Okay, not many. Stop the procedure? No, never stop. Okay, some other plaque modification technique? Okay. I took my guideliner and a guidilla, and I tried to cross the lesion, and I was able to cross with the balloon, but still dog bone effect. And during this inflation, the patient lost conscious. He had ventricular fibrillation. His son was able to defibrillate him 2 times, and he restored the sinus rhythm. The blood pressure went up, and we had quite a stable situation after that. And that was the angio.
So.
Nikolai, we have a question over there.
I mean, we always keep repeating that. Did you consider imaging to see what's happening in the circumflex? Could be just a calcium nodule, and it's really quite difficult to handle sometimes. Did you consider imaging because you've been going with wires and root ablation and so on? Did you try to do some imaging?
We discussed about the imaging, but it was so tight and we couldn't cross easily with balloon. And our IVUS probe, it's really hard to cross with IVUS probe through this kind of lesions. Indeed, we decided to proceed. And I was quite surprised to see that we have a...
May I ask a question?
Great. Something in LAD. Yes, that was. Yeah, I saw it immediately. I said we have a nice flow in circumflex, but something's wrong in LAD. This is my second shot, and you can see in the middle of the LAD this part and thrombus and TME, let's say 2. Between 1 and 2 in LAD.
Is it thrombus or is it the bit of the catheter that was migrated?
It's a thrombus. It's a thrombus. This one. Yeah, I'll try. Yeah.
Like the tip of the catheter, isn't it?
It's something circle in mid LAD. And the flow, it's not so nice. That's the reason of the disturbance, rhythm disturbance. Okay, let's
just one question.
Yeah, the right coronary artery. Did you show us the image? I can't remember seeing the right coronary artery. Was it all right? The RCA, was it?
RCA, I showed you.
All right,
it was nice, 30–40% diseased right dominant. Okay, how to deal with this complication? To administrate 2B3A inhibitors, call the surgeons, try to pull out this something, or leave it and DAPT long life. Who will use the GP2B3A inhibitors? Okay. Okay, surgeon? Yes, okay. Try to pull it out. Oh, majority. And leave it and DAPT long life. Take the microphone, please. Yeah.
You should restore the flow as soon as possible. That's number one. In this case, I will give medication and I will try with mechanical aspiration. And if I didn't restore the flow, I will try with stent implantation to restore the flow of LAD as soon as possible. Yes, it will be a life-saving technique.
Yes, this is the most important thing. That's why I'm asking about the drug administration to solve the problem with the thrombus, because it's a mechanical problem. Okay, what I did, I passed with the wire. I was really convinced that I'm through this tip of the catheter. It's a tip of the catheter. I inflate the balloon and try to pull it out. Go, 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 go. No, it's out. I tried several times to cross in the middle of the part, but it was not successful. That's why I said, okay, let's finish this. And I have a question, but I told you what I did. But we didn't call the surgeon. Probably this with the APTA, it's okay. Snaring, it's an option, but we don't have such a small snare in our cath lab. That's why we stented the patient. The LED, 3022, nice opening of the stent. And we have restoration of the blood flow the patient had some complaints of chest pain, ongoing chest pain. I said, oh, what's going on? And the circ was closed. And I said this should stop, and I tried to open it with some balloons. I passed, we restored the flow, and we decided to stop smartly, I think. The patient was pain-free, normal ECG, and we have a quite, let's say, happy end. And we asked the patient to come electively for a PCI throat ablation when we have a new bottle with gas. This is my fluoroscopy of the head, but at the end you can see that's this plastic part in the circumflex artery. After that I show you that it's quite tortuous, calcified, and my microcatheter didn't cross. Yes, it's there in circumflex, and probably during the root ablation, I pull it out in the left man, and during the injection, I inject it in the LAD. And that's my take-home messages. In such cases with device lost, it's somewhere in the legs. This strategy doesn't work extremely well in 100% of the cases. About check of the equipment, I mean the bottle of gas and so on. It's quite important before such a not so complex, but let's say complex procedure. And only one exception from the classical nightmare case is that was Thursday afternoon, not Friday. Thank you for your attention.
Thank you very much. We have to move on.
Can I ask?
We have to move on. Okay. Thank you.
So the next presenter is Paola Motta from UK.
Hello. My case is very humble compared. My message always about complications is how can I avoid them? That's my true attempt at. I would like to know the brand of those catheters that you guys have been breaking so that I don't have it. That's really nice. So this goes a bit like this was also a VIP, so it always helps. So 70-year-old retired European MP, this is a VIP for us. Hypertensive, very previous, with previous right carotid endarterectomy, high BMI, asthma, cigar smoker, good lifestyle. He was on the usual medication for cardiovascular disease, and because of being an MP, he had annual exercise tests checkups, European style, not UK. 5-minute ST depression led to all the cardiac investigations, normal echo, blood tests were okay, and he went for a CTCA, which is the current guidelines for assessing coronary artery disease, and he had 3-vessel calcification with a calcium score of over 2,000. And so he proceeded to coronary angiogram. These were the images. I don't know if you see anything here. Anyway, so the LAD was studied with an FFI that was negative, and my colleague that did this angiogram privately said, Paula, this is a very nice case for you to do a rotablation privately. I don't think privately and rotablation work well together. So actually I said, no, not privately. Sorry about that. Does it click? Yes. So these were the images, and so I would like to know your setup about this case. So which guide would you choose? JR4? Votes? AL1? AR2? So majority AL1, but not everybody voted. 6 or 7 French? 6 French? 7 French? More 7 French than 6. Would you go for calcium modifying techniques or no, balloon first? Microcatheter will do. No need for any special techniques. Yes, it's clearly rotablation. And maybe in current times, microcatheter will cross and we could move to shockwave. very few people vote. So I looked at this and I thought this was truly a rotablation case. That was a big chunk of calcium. Nowadays, today, I wonder if it could be a shockwave case. However, it's a nodule, so shockwave doesn't always work as well. That's it. In your experience, what would be the most likely complication in this case? Perforation? Dissection? Anything else? Both? Yes, lots of fun. So would you do this privately? Who would do this privately? Do you have high insurances for your private practice? Sorry? Oh, are we not a surgical center? And actually, does a surgeon ever come to your cath lab? When I used to work in a surgical center, I learned they don't want to do it. So I carried on doing everything. Right, so I chose 7 French with a glide sheath at 6/7, and I chose a JR4 guide. I didn't think I needed too much support. There's some S-Roma along the proximal end as well. So this was my go-to. It was quite challenging to actually advance the wires, so it needed support with the corsair, and I used the microcatheter to exchange the rotor wire. So this is my standard practice. I always tend to use a 1-pipe butt start. So on that case of that you used the new kid on the block, Orbital, I was a bit surprised. I would have used a small burr and probably would have avoided the big sludge downstream. It was a very interesting case, by the way. And my technique was taught in Austria, and it's 100,000 RPM rather than 180 as other countries do. So this was rotor, and this was the result after rotor, and here moving, this was the result after rotor. Complications? Anybody? No? Right, so then I inflated the balloon, and it looked like it was expanding well. And then this was the next picture. As you can see, I had advanced the second wire for, sorry, let me see if here I already, so my technique was always to bring a second wire. So I had the rotor wire, advanced the second wire. On the second wire, which was Zion Blue, I put a 275 balloon, inflated, and then it was this. So I have 2 wires, the rotor wire and the Zion Blue, and this expression by now. Right, so it was a dissection. So what would you do? So, right, advance the balloon on the Zion Blue wire and seal it. Gosh, nobody, that's a 0.
Just to get the sequence...
Well, one at a time.
Sorry, just to get the sequence correct, you had the rotor wire down, and then...
So yeah, so my usual process is, so microcatheter, Zion Blue with microcatheter, exchange the rotor wire, rotor bladed, advanced second wire, ballooned.
And you ballooned on the second wire?
Yes, it's
and
shorter.
You were sure the second wire was in the true lumen?
Was I?
Yeah.
I don't know. I thought so. It didn't have any resistance. It went through. The pictures were nice. So that's the first question. Was this a dissection caused by a balloon in the false lumen?
Because it all seemed to happen after the balloon.
Yes.
Okay.
Hence, unexpected. By the way, this was a very chatty patient. He stopped talking at this moment. He was not so happy. Yes? Say that again. I have a dissection.
Do you have a dissection proximally due to your guide catheter?
Do I?
I'm not sure. I see double contour, but I'm not sure.
So if we go back, sorry, here. I don't think there's any dissection there. I think just the guide is maybe hitting the conus branch, but there's quite diffuse asteroma proximally.
It was like a branch in a small plaque.
On this view, you may see it's not a very normal, but I must say that my attention now then chatting to the patient at the same time as doing a rotablation, which some people do, now was completely focused at the very end. Yes.
Why did not use the first wire? I mean, you
yes.
know it's,
Why didn't I
change it or even cut it to go faster and use it as a regular wire? Or you can change
That's
with
an option.
Microcatheter.
In the past, that's what I used to do. Sometimes the reason not to do it straight away is if I want to go with a bigger burr, my wire is already there and I don't need to do 2 exchanges. Also, using a 3-meter wire is a bit of a hassle, so I tend to. And since I went to the UK, that's what they do there. So it was a buddy wire.
I just want to say, so the spirit of this meeting since the beginning, more than 20 years, is that people stand there up front, in front of all of you, and we always make mistakes. So we know that there are mistakes, and then we don't have to ask, why did you make this mistake? We should rather try to construct a discussion and say, yeah, probably shouldn't have done that. So, of course, we know what happens here. It's not a guiding induced. It is because we all mostly do that. You know, we rota, we exchange, we put the micro again, and then we put a regular workhorse wire, and then we finish the job. But here, yeah, for once you did it differently, and then you had a complication. So we know what the issue is. But I would really ask you for the coming 2 days to work on a positive, constructive spirit towards the people who present their cases here. Don't take it wrong, but it's important for the people who stay here.
Those are very kind words, but I've been here. I've passed the stage of feeling accused in front of an audience, because otherwise I would not be a woman in intervention. But here we go. So if we, no worries, 5% of the UK. Yes. Anyway, so what I would say, so first of all, yes, immediately I thought, I probably was in the wrong place, but I wasn't 100% sure. There was absolutely no resistance, and on the previous image I had not guessed that there was any false lumen. So I don't know, but obviously that took a big part in my decision of what to do next. So obviously I did not advance the balloon on top of Zion Blue. I then advanced the balloon on the rotor wire, or actually no, what I did was I removed the rotor wire with a microcatheter, exchanged to a Zion Blue. I knew that it was the wire that was in the right place. So this is what I've done. So I think it was caused probably by the second wire. I didn't have any impression that it was caused by the rotor ablation. And then what I did was I inflated a 3030 balloon to try to seal it, and I achieved this. So the next question is, I restored flow, how much do we stent? Do you want to tell me how many meters of stenting? Say that again? Imaging would be helpful. Why would it be helpful? Actually, that's a very good point. You need a microphone because the other guys online don't listen.
You're in the right position now. You're happy with the wire, isn't it? So you
want to see the extension? Say that again.
You're happy with the position of the wire already because you're.
I am always happy with the position of the wire.
So basically,
I know this is the first wire I used.
I think.
And I used the sorry, just to repeat. I had a rotor wire. Yeah. I advanced the microcatheter and I advanced the second wire. So I know my wire is in the right place.
I mean, here you need to know the extension of the dissection and then the landing zone for the stent if you're going to stent. So that will give you an idea of how long the stent will be.
So do you stent the whole of the dissected segment or just the entry point? You stent the whole of the extension. Does anybody just stent the entry point? Are you concerned about tooth spacing effect? You're not.
It's a long segment.
I need to repeat everything you said so that the audience hears. So you think that it could be a dissection that's extending, okay?
You have removed the wire. Again, that would have
do you mind using the microphone so that the audience outside?
See, the wire which is right now, it's a Simion blue or it's a rotor wire? Cyan blue. You would have again, once you have changed the position of the wire, again it would have caused an extension of the dissection, which can also happen. Because there was some streaming in the...
No, obviously you cannot tell, but no, because I advanced the corsair right to the end of the rotor wire before removing my Zion Blue. So I knew I was 100% in true lumen by now. That's why I didn't think I needed imaging. But your points are all valid. They're all questions we have to ask when we're doing this. So
because, as you said earlier, you asked, the first slide was, how will I know whether I'll have a complication? But you have invited your complication by keeping two wires and doing a pre-dilatation.
Aren't I happy? private patient. I knew I shouldn't have done it privately. I didn't do it privately. I'm an NHS worker. Yes, key worker. So, how much stent? Yes, hello.
Hi, doctor. I'm Kim. I'm from Japan. So initially I was from Malaysia. So I underwent my interventional fellowship in Japan. So Japan is 100% IVUS guided,
yes,
or imaging guided.
Or
so
OFDI,
last
yes.
time before I went to Japan, so I was thought like, this kind of situation, wire will be fine, angiogram will be fine, all good, we know where is it. We just look at the flow, things will be okay. But after I'm in Japan, I realized before rotablation, what they will do is they'll look at wire bias, they'll look at any calcium nodule. They use very big size, 1.75, 2.0, 2.1, go maximum speed, 240,000 RPM, that kind of thing. I never seen in Malaysia, we don't do that. So I see that, then whenever complication, what they will do is IVUS, 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 IVUS. So then they realize what happened. They realize where to stand, where to land the stand, how long to stand, and optimization of the balloon. So I think after I'm in Japan, so I changed my mind. So I think that yes, financial constraint is always an issue, but if we push slightly harder, I think we probably can do safer intervention in OM. Yeah, I mean, if I were in your situation, as of now, I will pull out my IVUS and have a look on the IVUS and see what kind of things happen. Is it dissection? Is it, where's the entry point and where should we stand? And I think that's going to make our life much easier. Thank you.
I think that's a very reasonable point. But tell us, what did you do?
I didn't do IVUS, I'm afraid. But I do agree. I've been growing, this is a case of 2017, I've been growing a lot in my use of IVUS. Now I do at least 25% of my cases, but not 100. And I would never use 240 RPMs, 1,000 RPMs. So I've seen a lot of complication cases from Tokyo and Japan. Wonderful. Don't want to be in their shoes. Yes, no. I love my modest complications. Right, so more ballooning to spatial effect, ready to stand. So I ballooned the segment trying to improve flow there. I didn't want to go over that bend, so I started by stenting the entry point, which had to be where I had ballooned, I thought, and then put a second stent, biometrics, by the way, Ignacio, and although I don't have any shares in biosensors. This was when we were using biometrics a lot. And so then I had this. Where was the colleague that said, do I have a dissection? Was it you? Do I have a dissection? Yeah? Do I have a dissection? I said, no, am I relieved? Have I finished? Am I better? No, he did the dissection. That's interesting. Right, so we're coming here, and I'm deciding, am I going to stent this bit or not, a bit more? And I decided yes, so a third stent goes in. I decide not to go over that bend, and I think I'm about to finish my case, accepting the result, when I notice this. In English, we say, excuse my French. This is the moment we swear heavily. And we go, oh, now I have a bit of a bigger issue. What issue? Sorry? So what do you do now? I hope you all recognize an aortic root dissection. Sorry, I'm talking to an experienced audience. Right, who calls the surgeons? One surgeon, right? Who calls, gets a better intervention cardiologist? Nobody. We are all the best, aren't we? Yes. Seal it. Place a stent at the ostium of the RCA. Yeah. Yes. Me too. Pray. It will seal yourself. No. Okay. Praying is always there, but yes. Right. So I decided to seal. By now I'm counting my blessings as well. So I sealed it with another biometrics, a 4.0. I made my best to be at the ostium, covering it as much as I could. And this was the final result. Oh, by the way, we also did echo to make sure, because it was such a big dissection at the aortic root that I was wondering if I could seal it properly. So, final pictures. What is the next step? Nothing else is needed. It's sealed. Patient can go home in a couple of days or 4 days. Order, sorry, anybody? Nothing? All done? Good. 4, 5, 6 people. Order a CT for follow-up. Majority so far. Order a CT and refer to chiropractics. Nobody sends to the surgeons except our friend. Order CT, surgery will be mandatory. Well done. Right, order the CT. Here we are. Yes, it was the biggest dissection I ever caused. Right, so it goes up to the right carotid, which helpfully was already operated on before. So that probably held it there. He didn't have any neurological signs. He was talking to me all the time. I didn't tell you a little bit of a fait divers. This gentleman wanted a very, very quick private PCI because he wanted to go to Spain before going to before Christmas. So yes. So hello, Mr. M. But I'm afraid you can't go to Spain for Christmas. Oh, very British. Very good. Oh, you need to go to London instead because we do send to chiropractics because we are a non-surgical center. And at the time, I couldn't actually tell him whether he would be operated on or not because this was 5 years ago. And I can tell you that I was not expecting to have a surgeon that could actually hold his nerves, which he did. So they repeated the CTCA. This was a 14-millimeter intramural hematoma along the whole of the ascending aorta to mid-aortic arch. He remained stable, no evidence of organ malperfusion. His blood pressure was extremely well controlled. Remember, that was one of his risk factors. And he had another CT 5 days afterwards, which showed reduction in the hematoma. He was discharged on dual antiplatelets and antihypertensive medication. 3 months later, I had the privilege of repeating the CTCA. I had not closed the whole flaps, but everything was TIMI3 flow. The patient told me, "What will you do to my other artery?" Medical management is a wonderful thing. We have a lot of trials showing how wonderful medical management is compared to stents. No, Mr. W, you're not going to have another PCI with me. Your arteries don't like me. So 4 years later, we had the same conversation. He's been very well. He's enjoying himself, still his cigars, and a lot of walking in Canterbury, and no more stents. So I have these very nice pictures of recovery of the aortic root, but no journal wants to accept it. And he did very well. This is my team. Thank you.
Excellent case. Really well done. Does anybody have any questions, or do you have anything to add?
No, I agree. I will never use a second wire again, but
I think maybe one thing we need to, it was impressive also for medical legal reasons, you need to do a CT scan in this patient because it's a complication. But they mostly do extremely well, except for some exceptions, because of course there is no exit, there is only an entry. So I have seen quite some aortic dissections and impressive images, and just follow them up as you did. And I have even worse cases than yours that I can share, even worse. But most of them heal. It's amazing. So, and sending them to surgery is probably extremely at risk. And this paper telling you that when it's more than 4 centimeters into the ascending aorta, you have to send them to surgery. That's nonsense. It's not a scientific paper, but it's the paper that is always referred to.
So actually, I have discussed this with the at the British Cardiac Intervention Society, and the current practice now is CT, no need for surgeons, sit on the non-surgical centers still. Some centers, but those are chiropractics, don't even do CT. I think, as you say, that's quite bold. And it's also nice to see that the stent is actually sealing the entry point. Very, very, very recently, so 5 years later, I had another dissection, and this time there was this little flap under the stent that was not covered, and I didn't send them to surgery, and this also sealed in a few days. But that one scared me a bit, because although much smaller than this one, there was a flap underneath that was not covered by the stent, and I had never seen one of those. So yes, thank you. I think this was very modest compared to all the others, but
well, I think it was a great case. Does anybody have any questions or comments briefly? No? Okay. I think, Eric? Yeah, so we have a technology update, I think, which is...
Before short presentation on new technology by the industry, for those who have the courage to stay. But the industry will show us new devices and new technologies in very short presentations, and we should be done by around 6 o'clock for those who have the courage to stay.
Brilliant.
So, yeah, thank you.
Look forward to it.
So who is the first company? It's you. Yes, thank you. So we have, you can stay, Tito. Yeah.
Good afternoon.
Recording stopped.
Stopped? Is it supposed to start again or? All right, so good afternoon, everyone. My name is Maxime Pache. I'm working for Edwards, as you can see, as a program manager for transcatheter aortic valves. So it's a technology update. Really happy to open it, but I'm going to open it with something which actually goes beyond the technology per se. My colleague later on will actually show how this program actually nicely complement the great platform that we have today. So the Edwards Benchmark program is actually a program aiming at optimizing the overall patient pathway and ultimately reducing the length of stay. So you might ask, why do we need that, and why an industry is actually looking into this and putting some effort? So I like to start with that. That's the prevalence of severe symptomatic aortic stenosis. And as you can see, the distribution by age, this distribution by age quite eloquently shows that there is an under-treatment, both from surgical and transcatheter aspects. So it's quite striking to see that there is a large part of the patients that are actually diagnosed and untreated, or even remain undiagnosed. So we expect this big pool of patients to flow into the system, and we need somehow to treat them. More than that, and very quickly on that, there is a rising demand for TAVI that we see nowadays. I'm sure that you see that. Reasons are many: increasing aging demographics, COVID-19 related delays that still put pressure on the waiting list, staff shortage, and most importantly, probably the guideline expansion that we've seen last year, showing TAVI as a class 1A recommendation for patients over 75 years old. Also, and that's a great publication from the group in Rouen, we see that a third of patients are actually staying more than 3 days in hospitals for no real reason. Obviously, the remaining, so 2/3 of those patients are remaining hospitalized for complications, mostly conduction disturbances and vascular complications. And the objective of the program will be actually to minimize those complications, ensure that the patients that stay for no reason are discharged home as soon as possible. We will come to that. But before that, just wanted to show you a couple of data on where we are today. So from Switzerland, just a shout out to where we are today. The Bureau of Federal Statistics is actually showing that nice downward trend, actually, for TAVI length of stay, also from a surgical perspective. But still, 8 days, patients are staying 8 days at the hospital after TAVI. Very similar trend for France, with a bigger gap between TAVI and surgery, but nice downward trend also seen in France. From a German perspective, we also know that reimbursement is probably a bit less favorable, but also quite high length of stay. What I could see from the British Society of Cardiology is actually the only society collecting data on elective TAVI, only elective. So 5 days for elective TAVI. And I just wanted to compare here to PCI. We thought, just for the interest of data, that is actually quite nice. And Also, as PCI has evolved, you've seen that probably directly yourself. TAVI has evolved quite drastically over the past decade. We've moved from historical practices somehow that were very close to a surgical setting to much modern way of doing the procedures that are really closer, let's say, to a PCI setting. What we can, and we are quite lucky actually today to have two very powerful publications that are actually backing up those modern way of doing TAVI. And I'm talking about the 3M TAVR done by the Vancouver group in Canada, John Webb, David Wood, Sandra Locke, with whom we are partnering very closely for the benchmark program, as well as the FAST-TAVI group, which somehow was a European execution of the 3M study. So what we've come in terms of partnership with those two groups is a set of 14 evidence-based practices that really cover the entire patient pathway from admission to discharge. So I will not enter into detail of each of those, but the idea of the program is to create a peer-to-peer experience. So we have centers that have been through the program and that will actually enter or share their experience somehow with other centers that are trying to look at optimizing their practice. So beyond the cath lab, because obviously the peri-procedural is really about optimizing what is being done in the lab or the OR by minimizing complications. We are looking at what comes before and what comes after. What comes before is going to be about selecting the right patients eligible for an early discharge, communicating nicely on the upfront to the families and to the patient about their expected stay, and obviously, optimizing the assessment pathway, etc. Post-procedurally, very important, very rapid mobilization or come back to baseline with early mobilization, ensuring that there is a consistent protocol in place to deal with potential conduction disturbances, with the aim of taking a decision to implant or not a pacemaker before 48 hours. We see that possible, and at the end of the day, safe and timely discharge home. So all in all, the benchmark program is actually aiming at increasing hospital treatment capacity without increasing resource utilization. So aiming at create efficiencies and obviously with the aim of reducing the burden of hospitalization for patients, but also as a consequence from a cost perspective. More importantly, I think what comes first, obviously, is the patient safety. And when we talk about patient safety, we have those clinical targets in mind. They are very ambitious, obviously, but we believe they are meaningful for what TAVI is today and what TAVI is becoming. You might, what stands out usually is this 80% next day discharge home. Obviously, the idea is really about the philosophy of the program in a selected population. So really selecting upfront patients that can be eligible for a very early discharge. To finalize, just a quick word on how we executed this program. So we started a bit more than 2 years ago with 5 pilot sites across Europe that are now part of our faculty. We have extended this faculty, obviously, so that we could reach additional geographies. So today, we have more than 50 centers that have been through this program in Europe. And we are happy to say that half of them are currently recruiting patients, so in a registry, so that we can actually showcase, hopefully next year, with some data and publication, that this program is actually very beneficial, both from an hospital standpoint, but also for our patients. Thank you for your attention.
Thank you very much. It's very interesting. Does anyone have any brief questions? Who's doing TAVI here in the audience? Just out of interest. Okay, so it's a good audience. I believe biosensors, thank you very much.
Thank you.
Are now going to give us a technology update. Thank you.
Hi, good evening from my side also. We all know the biosensors stents. I think you all use them. And I'm here to talk about the biosensors TAVI system, which you might not know so well. It's the Allegra TAVI system. It used to be the New Valve Technology system, but New Valve Technology was acquired by biosensors. And my name is Max Kütting. I'm the head of R&D for the structural heart section of biosensors. So we're going to talk about the next generation of our TAVI valve, but before we do that, I think we need to get reacquainted with the first generation of our TAVI valve, because many of you might not have had experience with this. So this is the Allegra valve, and in a nutshell, the Allegra valve has a short supraannular nitinol stent frame. We have bovine pericardial leaflets and a skirt, and it's available in 3 sizes, which are 23, 27 and 31 millimeters. And it's designed for optimal hemodynamics and for durability. And I'll speak about some of those features that we have with the Allegra platform. So the first feature is we have radiopaque markers on the stent frame to indicate the new valve level. They also help with the alignment of the valve, and they also show us the height of the sealing skirt of the device. We have a tailored radial force distribution. What that means is just that the stent cells at the bottom of the stent are smaller, or they're designed differently from the ones at the top, so that the radial force actually is higher at the inflow section where we want to anchor, and then it decreases towards the outflow where we also have the commissural attachment. And this is where the commissures of the new valve are attached to the stent. And the reason that we have it like this is that we then allow for the stent frame to serve as a dampener, and this dissipates the stress that we have in the biological tissue, which is good because you don't want to have the stress in the tissue. This causes calcification, and by having this movement of the stent frame, which is about 1 millimeter between systole and diastole, we're able to decrease the stresses of the commissures by over 40% with this device. Having the different flexibilities also means that even when we have a very compressed inflow section, the outflow actually manages to expand. And this helps us a lot when we are treating small anatomies, we're treating valve-in-valve cases, and we get very good hemodynamic results. So just some of those hemodynamic results, obviously there's clinical data. I'm not going to go into too much detail about that as an engineer. But we also do benchtop comparisons just to look at the hemodynamics. And I wanted to show you, this is from 2 publications that were recently published, one in the JTCVS and the other one in JACC Interventions, comparing different valve platforms in terms of flow. And the Allegra actually had the best-in-class washout behavior of these devices, had the lowest flow stasis of these devices, which would be associated with leaflet thrombosis or things like this. We had the lowest rate of turbulence by a large margin, and we had the lowest gradient actually with this device. And that's also because of this design, and geometrically we have a very large orifice area, so that corresponds with effective orifice areas. So that's the Allegra. So what do we do with a valve like this when we have a platform like this? We want to build on this proven concept that we have. So we have the Allegra Plus. What are we doing with this? We're using 3rd-gen nitinol material. 3rd-gen means that we have smaller inclusions in the material, and this material is built for enhanced durability. And we're very excited that we get to use this. We work directly with the company that developed this for the next generation. We have a proprietary sealing skirt, which I'll talk about, and we have enlarged cells at the outflow to enable coronary interventions. Because of the shape of the stent frame of the Allegra, we're actually able to access coronaries after the intervention, either through the stent frame or at the side of the stent frame, which is unique with this design. But we wanted to make these cells even larger so that when you do a TAVI in younger patients and you need to go back and do the coronaries, you will have a chance to access them. Talking about the sealing skirt, the goal basically with the sealing skirt is to selectively seal gaps that you might have between the stent frame and the vessel wall where you can't really reach them. But you don't really want to, from my point of view, at least from an engineering point of view, you don't want to create a smooth surface on the outside, because a smooth surface just means you create a nice channel for flow. So what we are doing with our labyrinth seal is that we actually have selective elements that are distributed axially and radially along the stent frame that allow the valve to seal very well. So for the second generation, for the Allegra Plus, we have this labyrinth seal. This is what it looks like in the patents. I'm not going to show you everything here. You'll have to wait for the device and some of the clinical data that we show you. But the patent basically is that we have these sealing lip elements that we put on the outside of the sealing skirt to seal in places, and we allow these elements to fold out. And by having them distributed, we're also able to put more material in different places and actually seal very well. And even if there's a larger gap, they can fold out. So that's what we do with this. And that's the new valve in a nutshell. And of course, we have a new delivery system also for this new valve. So here on the left side, you'll see the current Allegra delivery system. On the right side, you'll see the Imperia delivery system, which we are going to now test in a clinical study. And just the features briefly. With the Allegra system, it was designed to incorporate a feature called permaflow, which means that we can implant without occluding the flow. So basically, the inflow and the outflow of the valve are compressed in the delivery system, and we can selectively release the inflow and immediately have flow. So you can implant without pacing with this system. It's fully retrievable, but it's not repositionable within this procedure because we're not able to recapture the inflow into the delivery system. With the Imperia, now we have a new handle design, which has a self-locking safety mechanism. So when you load it, it automatically locks itself. You can't accidentally release the valve, which I think is a good safety feature. And it's also fully resheathable and repositionable. What we maintain and carry over from the first generation is that we have excellent crossability through tortuous access vessels. We have a good usable length of the system, which is actually longer than other TAVI systems. And we have a highly flexible, hydrophilically coated 15 French catheter with an 18 French cartridge that's 6 millimeters on the outside. And that's the same diameter for all the valve sizes that we have. So in a nutshell, that's the quick technical presentation. And this is something to look forward to, I think, in the TAVI space. So thank you.
Excellent. It looks like we've got somebody with a burning question. If we could be brief, please, because I think there's... if we could help with a microphone.
Which innovation has this device? I think all these advantages has also by Eeckhout and by Edward. What is the extra advantage of this design?
Well, I think the extra advantage is, well, you could argue that all these valves have skirts. I think not all skirts are made the same. So that's one point, yes. I think one of the advantages that we have with this design is just the platform itself. So this is even something we have with the first generation. I mean, if you look at these results, I think you have to read the publications in terms of turbulence, in terms of washout, in terms of gradients. That's what you need for these patients. If you want to have a lower gradient, that means that the heart is going to work less, and that's what we're aiming for. Patient prosthesis mismatch is a very serious complication that actually has an impact on 1-year mortality. So you want to avoid it. And if you're treating a small annulus, you want to have a valve that's designed for optimal hemodynamics. I think that's an innovation that we already have with the first generation device. For the second generation device, I agree we are catching up with this skirt. We didn't see very poor PVL rates with the first generation device, so I think maybe there was not the biggest need to do this. But of course, in some calcification patterns, you want to have a skirt just to make sure that you're getting even less mild and maybe more none-to-trace results. But I think the innovative features are really just the design of this device is very different from the other TAVI valves when you look at it. Maybe not when you look at it like this, but they are definitely, when you look at it from an engineering point of view, having this feature of the leaflet stress reduction via the stent frame. That's not something that the other valves have, and having the largest geometric orifice area of all TAVI valves and having low gradients, to me, is very innovative.
Competition is crucial to improve technology, and Edwards had a self-expelling, but doesn't have it anymore for the moment, so you can't compare these devices. And to my knowledge is that potentially in terms of valve-in-valve, you may have additional benefit in terms of the risk of left main or coronary occlusion during valve-in-valve TAVI. You may very briefly, maybe in less than 1 minute, comment on that.
Well, we like to talk about valve-in-valve a lot because we have the Vival study where we had really excellent results. So I think that the benefit of this is you have a supraannular valve, but you don't have this upper crown that the other valves have. So in valve-in-valve, you're not interacting with the SDJ or with the ascending aorta, but you're just putting this device there, so it'll be easier to access the coronaries. And again, benchtop studies published by John Webb's group with this device showed that even if you implant lower, so if you feel you need to implant lower, you still have low gradients. So that's something that's very nice about this design also, I think.
Okay, and just, is the plus valve available now or not?
The plus valve is going into clinical studies now. The first generation valve is available now. So Allegra is available and is CE marked and available in various markets.
Okay, very interesting. Thank you.
Just a quick question. What about the cost? Is it comparable with other valves? The cost?
I think as an engineer, I'm not responsible for the costs, but yes, it's comparable with the other. So there's no premium price, but it is, of course. I mean, this is handmade in Germany, so you know this is a premium device.
So you mean the other ones aren't made in Germany? No.
Yeah, there's no other TAVI valves made in Germany. I don't know if made in Germany applies to everything. I feel that it does. We do create this valve with a lot of passion. I'm not saying that the other valves are not made well, but just saying this is not some kind of reduced price valve.
Okay. Well, thank you very much. Without wishing to start a war, can we have I believe Medtronic are now going to come and have a technology update as well. Thank you very much. Do we have the Medtronic representative? Here we go.
Yeah.
Le clic, double-clic, c'est ça? C'est le vert. C'est le vert. Et le double-clic, c'est ça la même chose là? Double-clic. Le double-clic? Ah oui, oui. Ladies and gentlemen, thank you very much. Thank you, Eric, for giving me this opportunity on behalf of Medtronic, giving you a short overview of the updating news in Medtronic. My name is Sharam Ghafourian. I am Medtronic representative in Switzerland, and I'm trying to be short for the next few minutes for this topic. Giving you where we have standing 5 years ago, 2015, when we launched Onyx. Now we are going to the next generation Onyx. It's going to be launched in fall 2003. The Onyx, if you like Onyx, you will adopt the next one. I think you know all the Onyx as a Geraud stent in your CAT labs. So we started almost 12 years ago with Resolute Integrity launch. Then we continue the journey with Resolute Onyx on 2015. And for this fall, 2022, sorry, we will launch Onyx Frontier. This is the name of next generation Onyx called Onyx Frontier. What is about? This time we just focus on the delivery system investment because we wanted to keep the polymer and the drugs. Otherwise, we have to go through the whole as you know, certification process with clinical trials. We have a solid and robust result with clinical trials from Onyx in terms of drug and polymer and the stent performance itself. This time we just keep the focus on the delivery system. So the next generation Onyx is going to be Onyx in Frontier with a new delivery system, which is the new balloon, with a dual flexible balloon in terms of construction, which gives even much better than what you know as Onyx, which is, I guess you agree, is one of the most performant stent in the cath lab. The next product will be already launched last year in Switzerland. It is the new dry cryotic balloon of Medtronic called Prevail. The same, the focus and investment all done on the delivery system. Just roughly to remind you, before Prevail, we had Impact Falcon balloons from Invatec, which was acquisition by Medtronic some years ago. And we keep the same drug and the same polymer, but just change the delivery system within Prevail. Also with a new balloon. What is new is the whole concept of the coating technology. We inflate the balloon, we coat, and then we de-inflate the balloon and we package, which gives the almost literally the chance of keeping 65% of the drug on the balloon when you start to pass across the guiding catheter until the lesion, especially within the calcified lesions. Improvement in the size matrix. So we can cover with DCCV from 2 to 4 millimeters, small vessels to large vessels. And the last but not least, it's our huge, let's say, focus on the renal denervation, which is the next 4 years of Medtronic, the focus in interventional cardiology. What is about Simplicity Spiral? Simplicity system is a combination of the multi-electrode catheter with 4 electrodes for ablation. We have automated radiofrequency machine. 6-phase compatible with rapid exchange system 0014. And the whole background of the renal denervation, as you might know or you might remember, it's back to 2010 when we acquisition Ardian company. So we started the whole program, clinical program with HTN1 and 2 and 3. It was quite challenging because the HTN3 was not really, let's say, quite compromised results. And we give a lot of, let's say, cost highly expensive price for these trials. But Medtronic didn't give up because it kept continue by improving the trials in more rigid and more disciplined way with respectively Espiral, HTN, off-med, on-med, also pivotal off-med, on-med, also the huge global Simplicity registry. I'm not going through the whole, let's say, details in terms of protocol of the Ardian program in Medtronic, just giving you a summary of the just 3 months follow-up of the off-med patients. As you see, the both office and 24 hours, both diastolic and systolic pressure decline reduced in a significant way. The same with on-med. This is 6 months follow-up. Also significant reduction of systolic and diastolic in both patients, Sham and Ardian group. Interestingly, we follow up the patients at 3 years, and it's kind of on-mode, permanent on-mode. As we see, after 3 years, not only the effect is there, it's even somehow improving, keep going, they reduce the blood pressure. Right now, including SHUV in Lausanne, we are doing the largest registry in the world with more than 3,000 patients, all comers with a huge, large inclusion criteria. Up to now, we are exceeding more than 3,000 patients. And just in one shot, what is have been already published is this 3 years follow-up for this registry. We see in each group and each year the reduction of blood pressure systolic, which still keep going and shows the performance. And please don't miss on Friday, this is the Run Innovation Day. We start the day with the symposium at 8 a.m. and we have a nice workshop at 11 here in Shu. Thank you very much.
Thank you, Sharam. That was quite an impressive. Somebody somewhere needs an Oscar. Can I just ask, I'm interested, who's doing renal denervation or wants to do renal denervation? Because Simplicity 3 was a big blow, was that trial, but because we were doing a lot in the UK and then it kind of started, just really faded away, but it's starting to come back, hopefully. It's happening because you've got quite a diverse group of physicians from all over the world. Yep. Okay, I believe Edwards have got another talk, unless you've got anything else you want to add, Sharam?
You mean in terms of run innovation?
Yeah.
There is actually, in terms of, let's say, routine 2 system, Medtronic system, and there is a company called Recor who has one. And these 2 companies have the most robust and most, let's say, solid clinical trials with the midterm, long-term results. The specificity of renal denervation, which is also our challenge, it's, it's finished in the cath lab, but before going to cath lab, there is a whole process. We have to visit, or you have to talk to nephrologists, to internists, and create a patient pathway. But let's say that destination is the cath lab table, where we estimate this is the interventionist cardiologist's job.
No, I think that we were working up towards commissioning. We started doing it, and we built up the MDTs and the assessment process as you're describing, and we were doing quite a few with success. And then I think the trial was at Simplicity 3 that came along, and it basically killed it. Absolutely. And then there's these newer trials on and off that seem to be promising, and the impression is it might be making a resurgence. And certainly that registry data seemed quite impressive. Thank you.
You're welcome.
Thanks. Okay, Edwards, you going to come and update us?
Ladies and gentlemen, good afternoon. So the best for the last. Just kidding. Topic for this presentation is Sapien 3 Ultra. My name is Eldar Akhmetov. I'm a group product manager at THV Edwards. And the simplest way to describe Sapien 3 Ultra is really the device that's designed for patients with the long life expectancy, right? So it's we all know that these patients, they have different needs. So they're not only concerned about the outcomes that have immediate implications during the procedure, but it's very important to be mindful about the outcomes that will happen later on, about these silent long-term killers. Right, PVL, pacemakers, coronary access, etc. And so, speaking about those and taking paravalvular leak as an example, we know that it increases cardiovascular mortality in 5 years by roughly 23%. So very important to look at that. And while my colleagues were more focusing on the design, I'll be rather evidence-based. So I'll just say that based on the recent TVT registry data, we know that based on the 1,300 of patients, the moderate to severe paravalvular leak has been nearly eliminated, and the mild PVL has gone to single-digit numbers now. So that's certainly thanks to the skirt technology, but also the cobalt chromium frame that gives it the perfect circularity and the balloon expandability feature of the device. Now, when we talk about the new permanent pacemakers, we also know that it increases mortality in 1 year by roughly 31%. You can see the gray line representing patients that received the permanent pacemakers versus the dotted red line showing the patients that did not receive the pacemakers, and certainly the delta is very high. The same TVT registry data suggests that we have single-digit pacemaker rates, and that's certainly representative across different studies. You can pull up many publications from Europe too, as well as the JPEG. When it comes to coronary osseous, certainly that's an evolving need, especially when it comes to the redo procedure. Something we need to be mindful of We know that the occurrence of the PCI after TAVI, after patients receive TAVI, is roughly close to 4%, and about 1 out of 4 of these procedures fail. Mostly failing because of inability to re-access the coronaries when there is already a stent inside. So SAPIEN 3 Ultra is actually the technology, as well as the SAPIEN 3, that warrants unimpeded coronary access, and we know, based on the source 3 sub-analysis done by Giuseppe Torrentini, that one could achieve and re-access the coronaries in 100% of cases. Now, because my second part of my presentation is about hemodynamics, which is probably one of the most speculated topics in the field of TAVI, I would like to actually stress on this topic and kind of ask ourselves, what about the hemodynamics with the SAPIEN platform? And what I would like to share is actually, well, the fact that indeed prosthesis-patient mismatch is important, and it's important in the sense that around 19% of increase in mortality in 1 year when there is a severe prosthesis-patient mismatch, moderate to severe PPM. Now, what happens when there is a moderate or mild PPM? Actually, there is no really data that suggests that there's any clinical significance in that one. But speaking about the hemodynamics, there are really 4 noble truths that I would like to share with you, and probably it might trigger some interesting discussions because, but data is data. Let me just run towards the first one, and it's the fact that actually when you measure gradients with echo, there is no correlation with clinical outcomes. Whether you believe it or not, but let's look at it. Let's look into the partner 3 data. What you can see is the echo-derived gradients for SAPIEN 3 when compared to surgery. So you can see that there is significant difference and higher elevated gradients for SAPIEN 3. But when you look at the mortality in 1 year, actually mortality is 2.5 times lower. What about the Evolute low-risk trial, if you talk about the low-risk cohort? Well, the lowest echo-derived gradients, but again, not really translated into lower mortality. You can see mortality is comparable to surgery. Well, one might think probably to do something with the trial design. What about the randomized controlled trials which compare head-to-head? Well, if you look into the Scope 1 and Scope 2 trials, which actually compared the devices within TAVI space, you can see that SAPIEN 3 has got slightly elevated gradients when compared to Accurate or Evolute, but when you look into the mortality rates, that actually those were substantially higher, which almost shows the reverse correlation. Now, one might think, okay, maybe there is a class effect. What about if we just look into the SAPIEN 3 isolated? And again, what we see, if we take 20mm valves separately to all other valve sizes, what you can see is that fairly larger millimeter mercuries in the gradients actually do not translate in any significant difference in mortality. So what's the problem? Why is that happening? Why shouldn't gradients, which are important, translate into mortality? And the reason is very simple. There are 2 ways to measure gradients. One is invasive method, and typically for that you use the pigtail catheter. So you measure the systolic left ventricular pressure, and then you measure the systolic aortic pressure. And then with a very simple math, this is the golden standard actually, with a very simple method you basically deduct and you arrive into the peak pressure gradients, right? What happens with the echo when you measure with echo? Well, echo is not designed to measure pressure. As simple as that. It measures velocity. And then what it does is you apply the complex Bernoulli equation to arrive into the pressure. The problem with this approach is that it was developed in the 18th century. It was developed 300 years ago. Since then, we understood a lot about the human dynamics, the liquid dynamics, right? We understood a lot about lateral fluctuation, about the turbulence. We understood a lot about the viscosity, right? So all these different categories. And so it's just the obsolete method. And so what happens is that really what defines blood flow pattern, right, is the velocity, the speed of the blood. The interesting is when you have the linear laminar flow, so basically the blood, in the ideal tube, let's say, there is no disruption, and therefore, when you measure with echo, that's designed to measure velocity and not pressure, and when you apply the Bernoulli equation, the gradients are going to be elevated. It's a simple methodology, right? When you look into rather the turbulent flow, if something impedes the blood dynamics, you can see that by measuring, when echo measures velocity, it certainly measures lower gradients. As simple as that. So there is nothing really new to that. So Eeckhout really overestimates the pressure gradient in the valve with laminar flow. Yeah, just and so if you look into different valve designs, what you can see is actually the platform is different, and so it might actually translate into the variances in how you measure, the gradients. This is the data that comes from Brahim, and what you can see is that probably you should be looking into more of the right side. So there is the Doppler gradient and invasive gradient. So within the study, measured basically, in the same patients, and what you can see is that slightly elevated Doppler gradients were actually translated in the substantially lower invasive gradients when you measure with the same pigtail. And so that's just kind of, it suggests that, Eeckhout is a bit overestimated, and that's roughly 1.6% according to this specific publication. So again, something to think about. There are a couple of trials which are ongoing, like discordance trials that are looking into this phenomena. So John Vapp is one of the PIs who looks into that. There are really incredible outcomes that are coming, and I think it might slightly change the way we think about, the whole concept. And so we believe that Eeckhout-derived gradients should not be really the primary reason to choose the valve. And when there are some elevations in the peak pressure gradients, certainly this should be followed up by further investigation, and that's pretty much what we suggest. In summary, I just wanted to say that Sapien 3 was designed for lifetime management, looking into outcomes that have the long-term implications. And when it comes to hemodynamics, there might be some overestimation, so just be careful with that. And don't be driven by that as a primary reason to choose the valve, because there are other things that we need to account for holistically. Thanks for your attention.
Brilliant. Thank you very much. I believe you had a question or a point, but I think I would echo Eric's earlier sentiments. Be gentle.
No, I was first. I have a few comments. First, I'm not against Edward's valve at all. Just I was shocked by this slide showing that when laminar flow is laminar, we have higher gradient. The first thing we learned in Eeckhout, when we have laminar flow, we should not measure pressure. Okay, saying that Eeckhout is not a good tool to measure gradients, all the guidelines, we do TAVI when we have a gradient, a high gradient on Eeckhout, that's due, that's all the solid data showing that this gradient correlate with outcomes and with hard outcomes. And saying that hemodynamic effect is that may not affect mortality, hemodynamic result should be measured on the long term, not on 1 year mortality. Okay, these are my few comments.
True.
Thank you, great talk.
Thank you. Just maybe a couple of comments. I agree that hemodynamics is very important. I agree. The whole definition of aortic stenosis is to solve the problem, right, of hemodynamics. Regarding the discordance, actually there's something interesting that we might want to, and we'll pretty much hear from the trials which are coming. When there is aortic stenosis, when you measure gradients before it crosses the valve and after it crosses the valve, there is a bigger delta between the P1 and P2, right? And there is a higher margin for an error. Actually, lower margin for error, I apologize. When you have some stent inside, and I'm not dropping brand names, but just some stent inside, the P1 and P2 are substantially smaller, they're more or less equal. So the margin for error is actually substantially higher. And again, that's something to account for. So that means when there is a stent, Eeckhout might not be the best tool to use. When there is no stent, when there is pure aortic stenosis, actually there's much more concordance, and it kind of makes sense to rely on Eeckhout while identifying aortic stenosis. So just again, something to look at, but there's more to come, certainly, as far as the publications and presentations.
It's true that what concerns us is gradients that go up over time, as you mentioned. But we are sometimes frustrated by gradients we don't expect in a perfect TAVI according to our simple, manual guides. And you all know, you agree that we don't get it. There may be other factors that contribute to higher gradients that we don't expect. We don't like 20 as a mean gradient, but sometimes it happens. And yeah, I don't know, Tito, you may comment on that.
I would completely agree. Certainly, I think on average, you get a higher echo gradient at the end with an Edwards. I think nobody can really dispute that. But personally, I think the outcomes speak for themselves, and they extend for more than just 1 year. And there is more to it than just the end gradient. I think the dynamic gradient over 6 months, if you start off with a gradient of 20 and you come back and it's 40, that's a much bigger problem.
Yes, I think that the measurement of by hemodynamic are not always true too. Conversely, I have some cases with a big gradient before TAVI, and in hemodynamic it was not very high, and the evolution was not good. So I think that we should be cautious with the hemodynamic gradient too, because sometimes due to the procedure we could have some low pressure, and the evaluation is not so good.
Thank you, Eric. You're about to sum up? Or?
I think you did. First of all, I did a great job because it was tough to get. We are only 10 minutes over time. I think I would like to thank, first of all, the attendees to stay, because thank you very much. The technology updates, our partners, the industry, need their place, and I'm really happy that you stay there, because it's very frustrating for them to speak in front of 10 people. So thank you to all of you. Quite some people will be coming in this evening. You will see them tomorrow. And we have asked Malcolm Bell. If you don't know him, Malcolm Bell is the vice chair at Mayo Clinic of Cardiovascular Disease Department. And I'm giving a really tough job to give a lecture tomorrow. He's starting at 8:20. And his talk will be about how skills evolve over time and what it means, what it impacts on our career. So I'm looking forward to what he will tell us, and then the next of the day, which I think will be very exciting. So I apologize for the weather. It's unusually not so good as usual. It seems to be raining, that's what I saw. But have a nice trip back to your hotel, and see you tomorrow morning at 8:20. Thank you very much.